I mean, so this is pretty much what we're planning to do. So as you were discussing this, I've wired both vessels. I've pre-dilated the side branch. I'm about to pre-dilate the main vessel. And then I'm going to image the main vessel because I want to see, what size stent we're going to use, if there's a good landing zone, and make our decision based on that. Generally for DCBs, I don't like to image after I've done the DCB because it looks like a complete mess, generally.
Me neither.
And that would make me want to stent. So I rely on the result from an angiographic perspective. I generally don't like doing OCT because if you have a good result angiographically, invariably you will get medial dissections, predilate prees, 16 atmospheres.
I think in many ways that's what we're aiming for, isn't it?
Yeah, exactly.
Predictors of late lumen enlargement are a dissection greater than 90 degrees with extension into the media. Right? So,
Professor Mama, I have one suggestion regarding the side branch predilatation. There is some evidence if you use the cutting balloon for the side branch that reduces the chance of gross dissection. That is, if there is dissection, that is quite good controlled dissection. So after side branch predilatation with cutting balloon, DCB is a good option here also.
So I think that's a great point of discussion. We'll hear from Professor Mamas first, but then maybe we can get into a little bit of the details. What are your thoughts, sir, then on cutting balloon, then DCB, or scoring balloon, then DCB?
I like that approach.
Yeah.
I've just used a 2.0 balloon just to create some space. It was very tight.
Yeah.
I'm just going to do a cine now to see what we find. So cine. So I probably will use a cutting balloon here in the side branch. I mean,
not a lot of
there's
effect,
a lot of recoil.
Tons of recoil.
There's a lot of recoil.
So I think then that sort of brings us to what the process is around gold standard, or what we think is gold standard DCB PCI. Dr. Sultana, so are you imaging first, grading the plaque, prepping? Do you prep first, then image, then go back? What's your approach?
Have you got 2.5?
0.5.
Scoring balloon?
Yeah.
And Professor,
so we don't have a cutting balloon, but we've got a scoring balloon, so that's what we're going to use.
Professor, you're operating in front of a packed house, so this is really good.
So thank you very much for the question. So it's a very interesting and also challenging. We have a down one LED PCI now. This for the bifurcating lesion. So I think everybody will prefer for the single stand strategy. Then I will put another rewiring the bifurcating because almost the diameter of the both bifurcating and the main vessel are the same. Keeping in mind that, so we will rewire that. Then we will, if there is, again we do the IVAS. If there is no dissection, this is okay. If there is any problem with that, then we will think that I think the DB is better than another option.
Agree. So
I mean, there will be dissection. That's the whole point of using cutting balloons in DB. So you will have dissections. So I think the point is to make sure that angiographically, you don't have dye staining, you don't have compromised flow, and if you don't have any of those, then I'm happy. Let's go up.
So I think
we're just using the scoring balloon now. A 2.5, go up. 12, 14.
Dr. Raman, so what's your definition of an optimal result on vessel prep? Because we recognize the DCB is just to deliver drug. It's not the treatment vehicle. What are you looking for? I think Professor Mamas is prepping the vessels with a scoring balloon. Well, what are you looking for then? What is he going to do? Is he going to image this afterwards? Is he going to angio it? Is he going to do both if he does OCT? What are you looking for?
I mean, personally, I would do both. If I'm going to do like a good job and I want to do PCI optimization, I would try to prep it by doing some kind of imaging, get a sense of what kind of plaque it is, where the plaque has shifted or not, idea of size before I end up proceeding with the stenting.
And so you're looking for size, you're looking for, I guess, dissections into the plaque.
That's good.
We've seen the level of recoil, right? This is largely fibrotic. So he's going to need to release the fibrotic tension within that plaque, or we're not going to get expansion. And Dr. Reza, then what's your approach to sizing DCBs? Let's say he does the the imaging
Down.
and he sees a 2.6 millimeter vessel, how are you going to size the DCB? Are you taking a 225? Are you taking a 2.5?
After imaging,
Yeah, 14, 16.
it should be 1:1.
Okay.
Down.
So 1-to-1 balloon sizing with a DCB, low pressure, with a dwell time or a hold time, sort of depends on which balloon you use, but there's a variety of different practices out there. I think about 80. Is Upal in the crowd? Is Dr. Wickramarachchi in the crowd? He's a
16.
DCB expert, and I know he's coming. His point, having done a lot of the research with some of the UK experts in DCB, is
Down.
about 85% of the drug is gone within the first 15 seconds. But the extended dwell time also gives you some time to shape the vessel and fully dilate so that the vessel
That's
can
listening.
remodel around the DCB. So, you know, me personally, in my practice, I typically do either 2 30-second inflations or 1 60-second. But I don't think there's wide agreement on precisely the right
We'll do an
approach.
OCT.
You mean you do second inflation in DCB?
Well, let's say you're in a left main, they're not going to tolerate necessarily 60 seconds, but they may tolerate 2 30-second inflations instead, right, to make sure all of the drug is off. Though largely these are evidence-free approaches, right? You know, it is good to know that 85% of the drug is gone in the first 15 or
Early,
so
they want
seconds.
to lose the line.
So you
May
know
we
that if
have
they can't
some,
tolerate more than that, you're probably okay.
Yes, Dr. Karla, sometimes on balloon is not available because it is not so popular
let's
in
do-
our country. So
Let's
what I
do-
used to do, if the vessel is
branch.
2.75 and 2.75 DCB not available, 2.5 I used to take
Yeah.
and go
Yeah.
at a bit
At higher
higher
atmospheric
pressure.
pressures, yeah.
Yes.
So I think that's an important point that's being made. Then we'll ask someone to bring a microphone to one of our consultant discussants here. So the point being made is if you have a balloon that's not quite the right size, you can go up to higher pressures, recognizing that you can also break the excipient when you do that, right? And you can actually reduce the uniformity of drug delivery.
Give a fentanyl or something.
I'm Dr. Raza. My question is, if there is a recoil or dissection
What?
after the first balloon,
Yep.
would you like to put the drug-eluting balloon or not?
So maybe I'll throw that back
Sorry,
to
just-
Professor Mamas. Professor, the question from the crowd is, let's say you've done your vessel prep and
Yes.
you see recoil, do you use the
Yes.
DCB? Or is that the definition of inadequate prep?
I would say it depends on how aggressive you prepped. So if I've used a cutting balloon and I've still got significant recoil, the first thing is is the cutting balloon the appropriate size? And that's why you need imaging. If it is the appropriate size and you are still getting, a suboptimal result, then I think you have to then move on to a stent.
Correct.
But
That's
it's
the
very
key
rare that you would get such significant recoil after adequate ballooning. So we've used a scoring balloon, and angiographically, actually, it looks reasonable. So I'm just going to OCT it now and just see what we've got and then decide what we're going to do.
So very important point, right? In that the DCB is not the treatment. It's the bed prep that's the treatment. The DCB is the drug delivery vehicle. And so if the vessel does not respond to prep with release of the stenosis and improvement of luminal area, you're not going to end up using a DCB. Right? And I think the other point is an important one that was made, which is it's very unusual if you've actually prepped the vessel with an appropriate size balloon not to get release of fibrotic plaque. The one exception may be calcium that is under-recognized on the angiogram.
Great. So we've just done the OCT. So you can see on the screen, we've just done the OCT run.
Can we bring up the OCT, please?
So can we bring the OCT, please, onto the screen?
As they're bringing up, Sanjay, so one of the things I've experienced is that when we prep it and we balloon inflate it and we don't get adequate expansion, it's probably because we undersized because we were scared. It looks really small. So we're like, you know what? Now that I've tried a 2.5, let me take it up to a 3.0, and then I'll be a little bit more aggressive.
Absolutely. I think that's
you can
really
see
one of the
by
usage
IVUS.
cases for imaging too, right?
So
Can we bring the
if you can
OCT
see
onto
by
the screen,
IVUS, what is the
please?
size? So sizing of the balloon is, I think...
That's the
quite-
same point that Dr. Hashim's just making as well, right? Which is
Yeah.
if you've got a vessel size, you no longer have to guess on the size of cutting or scoring balloon you're going to use. You're going after the vessel size, EEL to EEL minus 0.25.
So what's the E? So can you see the
Wow.
screen now?
Yeah, we're looking at the OCT as it goes.
Yeah, so this is side branch to main vessel. You can see nice dissections.
Nice dissections coming into the media a little ways, but not crossing one quadrant.
Yes. So with this OCT finding, would the panel be happy to adopt a DEB approach, or do you think this mandates a stent?
I mean, I think you've got some dissections present, but let's just take another look at the angiogram, right? Because this is one of those ones where I think it's not all just the intravascular image. We may see the presence of dissection, but that doesn't necessarily correlate.
Yes, we're just going to take another angiogram.
Stenosis loss, yeah.
Professor Mama.
Yes.
Sir, till now I am very much prone to, that dissection is not flow limiting, number one. Even sometimes there is dissection if you keep a NC balloon for a prolonged period, that dissection may be sealed up, and subsequently even you have an opportunity to put the DCB. Because here, such a small vessel, young patient, even after 6 months on year, after putting the DES, late loss will be around 30, 40, 50%.
So I think we have to be a little bit careful making general statements around late lumen loss without knowing what the final result was like. This is the weakness of Syntax 2, even Syntax 2020. This is the weakness of the early studies from the 2015-2016 range that talk about late lumen loss. We have no idea what the actual stent result was. And if you look at imaging-guided PCI and you look at short-term late lumen loss, it's almost zero when you get minimal stent areas that are adequately large, right? So I think a lot of that data is going to start having to be rewritten. But the question that was asked was, when you look at the angiogram,
is it true for all small vessel, large vessel, late lumen loss?
Well, we'll see, right? I think the point was made that this is a relatively speaking small vessel, and so there is a reasonable approach to using DCB here. The challenge being that we've actually got to make sure that we've got an adequate preparatory result, and the presence of dissection is what you want, not what you don't want, right? What you want is the dissection, but with no contrast hang up in the wall and normal flow. That's really what you're aiming for. And in the CTO world, we get that all the time, right?
And that's what we've sort of got here. So if we play the last angiogram, play the last angiogram, please. So you can see there, I mean, the expansion's okay. I mean, I think measuring EL to EL, it's about 3.2 millimeters. So I think with a 3.0 drug-coated balloon, we're going to get good expansion. So the question here is, do we go with a 3.0 non-compliant or a 3.0 cutting balloon or prior to the DCB, or do we just go ahead and apply the DCB? So what would the panel say? What would you do, Sanjog?
Yeah, very, very challenging. To be honest, Mamas, me personally, I am not happy with the prep result. I think there is dissection certainly visible, but the release of stenosis, I think, is ultimately what we're trying to get to.
Yes.
And I'm not happy with the prep result. And so what was the size of balloon you used to cut or to score?
There was a 2.5, so I'm going to go up to a 3.
Yeah.
I'm just doing the OCT of the other vessel.
That's where I would go, right? What I would end up doing ultimately in this situation is take a 3.0 preparatory balloon, but do so at relatively low pressures. Because the minute you start to oversize, now you're going to get into the noxious dissections that end up with contrast in the walls where you're obligated to stent. And my hope is that with a low pressure but targeted prep approach in that segment of the vessel, you will release the stenosis enough so we're going to get a much nicer result with a DCB.
So we're committed to a DCB here, Sandra. We're not going to do stenting. Our primary goal is to do DCB.
I think at this point in that branch, what we have as a group summarized is that in that branch, a DCB approach is reasonable so long as the preparatory result is adequate. If it's not adequate, then we're in a bailout scenario then anyway.
So do you think we could take 3.0 NC balloon afterwards?
Well, so
yes, so currently I'm just preparing the main vessel for OCT. And then I'm going to go with a 3.0 non-compliant balloon to predilate the side branch and get a more optimal result before doing DCB. I agree with you, Sandro.
The plaque, you know, this is an interesting actually area of discussion, right? Which is how do you select the right balloon? What's the target, right? So the recoil isn't happening from the adventitia. The recoil is because of fibrotic plaque. And an NC balloon will, you know, you will, without increasing balloon size, be able to increase pressure on the sides, which for calcium is great. For fibrotic plaque, I mean, I don't know if it's going to result in the same expansion we hope for. My approach personally would probably be to take another scoring balloon and cut into that fibrotic plaque a little bit more aggressively. Whether it's a 275 or 3.0, I think is debatable. I would probably, in my world, I would take a 3.0 Wolverine and I would cut this open. And I would.
So we don't have cutting balloons.
Yeah. So or a 3.0 angiosculptor, whatever scoring balloon we have. Yeah. And I would take my time and let that, like these are ultimately cages that are on top of a balloon. So fibrotic plaque, ultimately the pressure underneath that cage is going to take time to translate into scoring of the plaque. So especially because we have a vessel that the patient's going to tolerate ischemia in, I would put that balloon up and I would hold it a nice 30, 40 seconds to make sure that that plaque has time to split against that cage and then slowly take it down.
With the wrong vessel you've gone.
Very expensive in organ. Wolverine is very expensive.
So
you know, 60,000.
Very real challenges, right? So this is one of those ones where
the scoring balloon is similar to NC balloon.
Yeah,
it costs only 12,000.
You know, so this is a good point that's brought up, which is that scoring balloons can be quite expensive. So in the old days, right, the poor person's scoring or cutting balloon is we'd put a second wire across. You can take typically a metallic core, something like a BHW. Okay, lay it across the lesion and then take an NC balloon and put it on top of the original wire and use that to cut. And you do multiple inflations so that your wire is moving on various sides of the plaque and you end up getting some sort of scoring with the secondary wire. I've seen in larger vessels even 3 wires put in, where you get one on each side of the vessel and you take the NC balloon and you take it up and hope that that's going to make the difference.
That's that branch.
In that case,
so we've done the OCT now of the main branch. Can we play that whilst we're preparing the side branch?
Yeah. So we're looking at the OCT of the main branch.
Yes. And this is a very different vessel to in terms of lesion characteristics. So maybe the panel like to discuss what we're seeing here before I say.
So General, can you give us an idea of your thoughts on the OCT image and how you would approach making a stenting decision based on what we see? Can we play that?
Play.
So lots of dropout behind, right?
Yes.
Right? Lots of dropout. That tells us that this is high attenuation plaque, so not fibrotic. Okay, there is some fibrotic and sort of mixed plaque there in the middle. This is the area of severe dropout. Okay. Oh, wow, this is very interesting. Not what we would expect, huh?
Go up. So what do you think?
Dr. Datto?
Down. So panel, what do we think?
Yeah, we're going through the panel.
Professor Rama, we are agree. Whatever you are thinking the same way, I think whatever you do, we are agreed with you. So anyhow, the lesion, till now, I think the lesion is not well prepared.
Yes.
There is some dissection, but that is acceptable.
Mm-hmm. So Dr. Raman, what are your thoughts on the OCT and what you're going to do next? You've got high dropout, high attenuation plaque without a ton of calcium.
Right. So I would try to like prep it a little bit more, do some more ballooning.
There's like only one thing that is, right?
Right, exactly.
Right, so Mamas, the consensus is we're inadequately prepped there.
Yeah, so this is the side branch. I've just done with a 3.0 balloon and I'm happy with the side branch prep. Mm-hmm. Can you see that? Just show the angio. So you can see with the 3.0 cutting balloon, we've got a much better preparation of the side branch.
Beautiful.
So I'm going to use the same 3.0 scoring balloon now in the main vessel. Can we just check the size? LTL, main vessel, please. Yeah, there.
Yeah. And the other thing that's worth mentioning, right, is if we're using the angiogram to decide on prep.
Yeah, that's fine. Just
right?
tell me
we need another view, right? You need a secondary view to ensure that the prep actually looks what it looks like.
Can you guys hear us?
Yeah, we can hear you. Go ahead.
Yeah, so 3.0 again, yeah.
So, I mean, that looks so
So
much
we're going to use a
better.
3.0 cutting balloon to prep the lesion better, and then
Right.
what we're going to do is then DCB the side branch, and then do a provisional approach
Perfect. Yeah.
across it in the main vessel.
And
So we're just now using the scoring balloon
In other way,
in the main vessel.
I think we're right on the same
Dr.
page.
Carla, you see the main vessel is well
Sorry, I
prepared.
can't hear you. We're getting a lot
The
of
main vessel is well prepared,
echo
well
here.
pre-dilated,
So can you do
but the
something
side
about
branch,
microphones?
Sorry, Professor Mamas, were you saying
Guys,
something?
I really can't hear you, and we're just getting lots of echo in the lab. It's really difficult to understand what you're saying.
I understand. There was just a little bit of discussion. So I
Balloon,
think
please.
I think there may be some confusion with a couple of
I
the
don't know
panel
if you
members.
can hear us. I can't hear you now.
Can you hear me now,
The
Mamas?
sound's gone off, but if you can hear me, I'm just pre-dilating the main vessel now. So go up there, up,
lower, yeah.
12, down.
Can you
Sound's
fix the
gone,
audio?
guys. Go up, 12,
Mamas, can you hear us now?
down.
I think the problem's on his side too, Sanjog. I think the problem's on his side as well. He's hearing an echo in the cath lab.
Have we
Yeah, that
lost
may be them.
I
Yeah.
can't hear a thing.
So, can you send them a message? Can you send them a message saying that we hear them fine, but there may
Down.
be an audio issue on the lab end?
Okay, do a cine.
We're listening.
Can you hear me?
Yes, we can hear you very, very well.
Great. So I've prepped the main vessel now with my cutting balloon. I'm happy with that. So I'm going to use the DCB now to...
And I think there was some confusion. So for clarity, in this view, the
Yes.
side branch is the superior branch, and the main vessel is the inferior branch. Correct?
Correct.
Okay. So there was some lack of clarity there initially. I think, understandably, because both branches are pretty big,
Yes.
right?
But I think I'm going to go for the inferior branch because the disease is just much more diffusely
Yeah.
distributed.
And look at the preparatory result with that extra little bit of time on the 3.0.
Yes.
Right? Like it's just so much better now. And the other point that we were making was when we're looking at a preparatory result and using the angiogram, because we don't really have targets on the imaging other than the presence or absence of dissection and scoring of plaque. What we're actually looking for is angiographic resolution of the stenosis. So what we're going to do then
we got
is
a
look in
long-
more than one view if
long
we do not
DCB.
see a satisfactory result in the view that we're
3.
looking at. Here, I think you see very nice release of the stenosis, so we're quite pleased. But if we didn't, it would be reasonable to look in another view.
Yeah, so we're just now trying to find in the lab the longest DCB or a long DCB that we have. What do you have?
Any particular, if you were in your lab, Mamas, do you have a particular choice or do you have a go-to that you usually use?
We're doing the solution trial, so I would probably use the solution balloon. That's the one that I have the most experience with. No, not 3.53 we want.
Yeah, I think on the North America side, RF, you guys have just agent, right?
Yes.
In Canada, we have choices. We have
What do you
had
have?
Pantera Lux for quite some time with Biotronic.
A 320.
We've got agent, and then there's the availability of
Do you not have any
Protege,
longer?
what's the other one? The long
Prevail
one.
is also from Metrolinx.
Essential Pro, yeah.
And Magic Touch is several
And
MSC.
Magic Touch, yeah. Magic Touch is available here as well.
So, your experience, you've used multiple ones. Which ones do you like? Which ones do you don't like?
Yeah,
Is
so
there a
I
discussion?
think that there's interesting discussions here, right? This comes down to balloon construction, excipient, drug delivery, target drug or target level, target pharmacokinetic transfer, and target drug
let's have the
concentration levels,
320. Come on.
and that I don't like. I mean, I don't have the data for those off the top of my head, though. There are some bench stuff that some of the companies are doing that are demonstrating Rougade balloons with drug stored within folded balloons is arguably the best way to ensure that you have an appropriate drug concentration. Boston Scientific's agent balloon has an excipient that is particularly good at transfer and adherence with actually crystalline drug that may stick into the walls that has been viewed on OCT. I think Professor Mamas is trying the solution. He's within the solution trial trying that balloon. What are your results with it like? Are you happy with it so far?
I mean, so far, yes, we've done quite a few cases, and we're really happy. And actually, the UK, I think, is a bit of an outlier in terms of DCB use. So the latest data, which I presented last week at the British Cardiovascular Intervention Society, is 16%, so 1 in 6 of all PCIs are done with DCB. And actually, some of the centres that really have driven this practice, the rate is over 50%. So over 50% of their cases are DCB. Do I agree with that? No.
Yeah, there we go. I was just going to get to is that reasonable? Is that justifiable in any world at this stage with the data that we have? Doesn't matter what company's balloon you're talking about.
I personally wouldn't. I mean, I'm not here to criticise my colleagues, but I personally wouldn't do that, and that's something that I highlighted in the meeting. But it's interesting, and even in ACS cases, something like 10% of all ACS cases are performed with a DCB. So again, my slight concern is that perhaps practice is overtaking what data that we have, and I think
I don't look at it as, honestly speaking, as criticism. I think it is, just as you've pointed out, an evolution in practice. But as we did with drug-eluting stents in the early 2000s, as we did with hemodynamic support in the mid to 20-teens, as we did with with stents in general when they were first brought in, right? Practice is always ahead of data, and I think that we're probably now entering a phase of PCI where DCBs are truly a promising technology. But like everything else, we need to learn how to use them and when to use them.
Yeah.
Exactly.
So we've inflated the 3.0 DCB. The longest that we had was only 20 millimeters, so it's not as long as I would have liked to have used, but I guess we use what we have.
But, I mean, you're across the bifurcation part of it, right? You're going to end up stenting over that segment anyway. Which brings us to another discussion point, right? Which is you've now got drug, paclitaxel.
Yes.
And then you're going to have a stent across it, which is going to elute a different drug, right? So in some of the bench testing, when you overlap DCB and DCB, there seems to be no problem, right? But when you overlap DCB and stent, there is positive remodeling, right? And we don't know the consequences of that yet.
So,
wow, what a lovely result.
I have a question, Professor Karla and Professor Mama also. So is it your daily practice to put the DCB first in the side branch, then the DES in the
Yeah, good question. So, Mamas, the question is, so you've DCB'd the side branch.
Yes.
And the question is, why DCB the side branch before you stent over it? Should you do it the other way around? And I do it the same way you do, and I have a specific reason to do it that way, but I'd like to hear what you have to say.
Yeah, because I think the problem is that if you do it the other way around, you then pass your balloon, let me just talk. You pass the balloon through struts, and then you've got a problem, an issue of potentially rubbing off your drug coating when you're trying to cross the strut. So I don't think that's good practice.
I think that's one of the reasons, for sure, right? You'd have to rewire and open the struts.
Yeah.
But to tell you the truth, for me, the reason I don't do it that way is because the whole point of vessel prep in that side branch is dissecting the bejesus out of it. And so then losing your wire access, stenting over it, and then having to rewire through 20 different dissections that you intentionally created is not a safe practice.
Yeah, I agree with you. So we're just prepping the stent now. So we're going to use a 3x30 33 science in the main vessel now.
And it's very interesting. So you're taking a 3.0 stent for that branch, right? But at the beginning, Dr. Dato, you looked at it and said, well, this is no more than a 2.5 vessel, right? So perfect example of where we do not size vessels well angiographically when they're diseased. You just can't. And I've heard Professor Mamas before at some of his talks say, look, 100% of the PCIs in my lab are imaging guided when I do them, right? And I take the same approach in my own. Canada now, actually, we have now government funding for intravascular imaging, where the doctors don't get any money for it, but the institutions are no longer penalized for doing what we truly believe in our hearts to be the right thing for patients. Right, and I think that is a very important point around leaping this type of therapy forward. Dr. Nishina's in the crowd. He's amongst many things an imaging expert, and in Japan, imaging is ubiquitous. Right, I think penetration rates are in the high 90% range, and were so for many years. Other than the rest of the world, Professor Akasaka as well is here. Same sort of comments, I'm sure, who've seen dozens and dozens and dozens of cases outside of Japan done without intravascular imaging, where you probably in your heart know the result would have been different in your hands because the system pays for imaging, and as a result you can get it.
Let's see what we have. Do a cine. So prep the balloon.
My question is, for side branch, do you do the lesion preparation first, then you do the IVUS? Or you do the IVUS first?
I think we went over that a little bit earlier, but the idea is you open, and what Professor Mamas did was we opened the vessels, made space, and then understood the plaque with an intravascular image. Then fully prepared it and imaged it again to make sure it was prepared. Realized it wasn't, prepped it, were satisfied on the angiogram, and then went over to the secondary branch.
So you size the side branch balloon by angiographic estimation first?
Well, you make space for the imaging catheter, and then you do the sizing on the imaging catheter. So, Mamas, we've got another 4 minutes left.
Yes, I've just deployed the LAD stent. The vein vessel stent. Just do
the Ramus stent, yeah.
The Ramus stent. So I'm just going to just show.
I think we're all excited to see what this result is going to look like.
Excellent.
Okay.
That's good. So I'm going to image now and then pot.
So that's a pretty decent reconstruction. There's a little bit of action at the distal edge there.
Yeah, I can
whether
see
it
that.
just
But let's see
requires
what
one
the
more
imaging
stent or whether
shows. And I suspect I'll need to post-dilate this. I mean, it's under expansion just after the side branch. But that's what imaging is useful for in this sort of case. I think, we assess, we look at the edge, we look at the expansion, and make sure we're happy. So we're just going to do the imaging now, and then we're done.
And then our friends and colleagues in industry who may or may not be listening here, right? One of the things that actually is an important limitation, I think, right? If we look at the edge at the distal edge of the stent, let's say there's no dissection there, and I don't think there is. Let's just say it's plaque, and we've landed in plaque that inadvertently is over 50% plaque burden. This is another usage case for a short DCB, right? Yeah. Cut it at the end, do a very nice DCB. As long as you get great luminal gain, you're good. The problem is the DCB is twice the price of the stent, three times the price of the stent, right? So if we're really going to develop experience with these therapies, I think it becomes very important for us to work in partnership with industry to make these devices accessible.
In our subcontinent, that thing is not like this. Stent price a bit higher than the DCB price here.
And the other thing, I guess, that we can work towards is some degree of uniformity. Because certainly in other parts of the world, I mean, if you go to India, for example, DCBs, many of them are more expensive than the stents. Canada, they're certainly more expensive. The poor United States is hooped completely. They're 5 times the price. So can you imagine can you imagine explaining to your administrator why you used 3 DCBs in one case?
Nope. And then you also brought up the question about imaging, right? Like I'm about 50% to 60% imaging, and I still have to answer to my administration why. Yeah. Why so high volume of OCT or IVUS?
This is a sort of personal anecdote time for me around imaging and how it guides PCI. My practice is, I have many friends in the crowd. I've been to Bangladesh. I've had this privilege many times. But my practice is largely complex and high-risk PCI. And I think when you don't do the right job for those types of patients, they are totally intolerant of imperfect outcomes. That delta becomes very large, right? So I had to justify this to my administration 5 years ago as well. But it was nice to show them that, amongst the 200,000 patients that had been investigated by 2021, amongst the 9 randomized trials that had been done in the countless registries, ultimately the administration said this is an ethical issue. And so we're just going to have to pay for it. Right? And that, I think, comes down to what the tough conversations sometimes we have to have, right? Where You come to the administration with a business case and understanding of what it is that you're trying to do, and the ability, I guess, in places like Bangladesh to be able to advertise around that and say, look, we do all of our imaging, all of our PCIs with imaging guidance, and so we ensure our patients the very best results. That's why you come here. Right?
Can I say something regarding this?
Yes, please.
I'm Dr. Rayan Anis at United. I mean, you just mentioned that, you have made imaging ubiquitous in Canada, but, that's almost next to impossible. In
No,
this.
the comment I made is we happen to be funded there now. We weren't before.
But I just want to say that I think, we are using imaging in 20% of our cases, and the rest 80% we are not. And I work in a very, I work at United. We also have to look out for our private patients and the end results. And I think our end results are quite good even without imaging. And many of my colleagues are doing, we're doing 6 month, 1 year, 2 year follow-up. Patients come to you. And the other thing I want to say is that, we're smart in the respect that our DCBs only cost even less than drug-eluting stents. So we're doing good when it comes to DCBs.
So the comments were around, sort of individualized results for individualized centers, which I think is a reasonable point, right? Like the markets for DCBs across the world are different.
Yeah, in our country, in India, in South Asia, DCBs are all
and so I think there is
less than stents.
There's an opportunity then, right? Right? What I hear from you, ultimately what I'm hearing from you is there's an opportunity in Bangladesh to take the lead as far as data generation goes around the use of these devices, because you actually have a cost paradigm that is different than the rest of the world, where in the rest of the world, the use of DCBs is cost prohibitive.
Yeah.
Here it's not.
No.
So you actually have an opportunity to generate the data that the rest of us are able to look at and follow.
Yeah, the only
because
thing is when
you'll have experience that we may not, right?
But when it comes to imaging, we have a lot of privilege.
Yeah, I mean, I think that's the real point, right? Is that whereas you might go to other parts of the world, whether it's the United Kingdom or in Canada, where we now have funding for intravascular imaging, and maybe that's the data that that you may choose to look to because it's aspirational, right? That's the North Star, where now you know that when you actually guide everything by imaging, these are the results that are different. You have the many randomized trials out there now that actually pretty solidly establish the difference in outcomes, hard outcomes with imaging guidance versus non. But I think we all have to take into account that we meet our patients where they are. And we meet our patients in the system that we are in. And we've got to sometimes make challenging decisions and hopefully point ourselves in the direction that we want to grow. So for you, I have the privilege of doing a live case at United tomorrow. I'm excited to be there. And I've been there with my friend Afzal many times. It's an amazing hospital. It's beautiful. I was here during COVID, during BRIC, and actually that's where I got my COVID test done. So it's a beautiful hospital, but I think if then there's going to be leadership taken within the community, it's going to be at hospitals like this where you recognize that this is where the growth needs to occur, and this is where we can contribute to growth. So we will follow and we will lead, just depends on what therapy.
No, I just want to say that, I don't think not doing imaging should be an ethical issue. I don't think that should come into this. Imaging, definitely you're doing a much better job, but with the experience of people who are working in the field, I know luminology is not the best, but imaging should not be taken into account as an ethical issue, which you mentioned.
The definition of an ethical issue comes down to the environment you're in, right? So what is ethical in one place, what is an ethical issue in one place may not be in another. So for us it was because we had funding and we had the availability of catheters. So then it comes down to the only reason you're not doing it is because you don't feel like it.
No.
It's a different thing here. And that's why I say you have the opportunity here to lead around the DCB space, and you have the opportunity to learn in the imaging space, right?
Okay, thank you.
So, Professor Mama, what was the post-dilatation balloon? Was it 3.5 for proximal part of the stent?
We'll use this as the last question, Mamas.
I've not done that yet. We had difficulty passing the imaging catheter. I think that we had wire wrap.
Right.
So I've taken the side branch wire out. I'm just going to tidy up the stent with a 3.0 balloon distally because it looked under sides, and I want to minimize contrast use, and then I will image and then decide what to do with the pot proximally. So just a small injection, please.
We're going to have to bring this session to a close now, Mamas, as we're a few minutes behind, but on behalf of the entire meeting, thank you very much for a really nice case, great discussion, lots of teaching points that were brought up. Okay,
No,
and
thank
with
you.
that,
It's a real
I'll-
pleasure. Nice to see you all and see you a bit later.
And with that, I'll ask Professor Akasaka and Professor Mominuzman to come up to introduce session number 3.
Just do it. No injection. No injection. Go up. Down. Down. Just in it. Don't take it apart. Looks good, doesn't it? I mean, the side branch is not great, but let's have a 3-5, short 3-5 balloon. Yes, short 3-5. How much has she had an ACT? Because there's lots of clot here. I don't want to. Okay, good.
Yes, we have a full presentation, right? Yeah.
Thank you very much. We are now approaching the session 3. They're very interesting topics. On this session, there will be 4 speakers on these topics. Is bifurcation lesion. May with Dr. Akasaka and some panelists, Dr. Tawhiduzaman, Dr. Kaisa Nasrullah, Dr. G.M. Farooq, Dr. Tamzeed, and Dr. Abul Fazl. May I request all the panelists to come in the dais and start the session. Yes, I think Dr. Akasaka, you just named the discussion.
Okay, let's start the first presentation. Yeah. The first presenter is Dr. Hidetaka Nishina, my friend from Japan, right? His talk today entitled The Role of Imaging Guided Left Main PCI. Please.
Okay, thank you very much, Professor Akasaka. Hi, ladies and gentlemen. My name is Hidetaka Nishina from Japan. It's my great pleasure to be here. Actually, it's my 5th time visiting Bangladesh. Okay, so I'm going to talk about the role of imaging guided left main PCI. I want to go to very simple. So why do we need imaging? Because number one, the left main disease is rarely focal. Even if it looks on no bifurcated lesion on the angiogram, when you do the intravascular imaging, you find most of them are complicated, maybe 111 or 110, something like that. So sometimes angio only cannot tell the type of the bifurcation lesion, especially for the left main branch. And left main is a very important vessel. So let me talk about a little bit of technical aspect tips for the left main IVUS presentation. So first, wire both LAD and circumflex, and hopefully image from the both branches using plueback, because then you can decide the sizing of the stent and the length of the stent, and from the lesion characteristics, you may decide whether or not the lesion needs lesion modification like calcium modification or other thing. And again, so you checking the vessel size, proximal and distal part of the bifurcation, which we can decide the balloon size for post-dilatation and proximal optimization PO part. And of course, in some cases, we can predict the side branch compromise from the information acquired from intravascular imaging. And technically, when you do the IVUS plueback, disengage the guiding catheter and maintain a coaxial relationship between the IVUS catheter and plueback should be completed until the outer ostium, at least for one branch, for example, for the LAD. the coaxiality is very important because when the wire is not coaxial to the vessel, you may get the wrong image with regard to the vessel size and lumen size. And actually, for the left main, actually the size differs significantly when you see the proximal left main to the distal landing zone, in this case, the LAD. And so this information can also only acquired by intravascular imaging using IVUS, or OCT is another way of doing. And with regard to the sizing, either EEM diameter, so the media to media diameter, or lumen diameter can be used for sizing. And it's an important thing is to avoid at a landing zone segment with a large plaque burden or lipidic plaque, because that a lipidic plaque at the distal edge of the stent is one of the major predictors of stent failure. And with regard to the stenting, actually the stepwise provisional approach is considered standard. This is a result from EVC main 1-year result with provisional approach, the main stenting to the main branch, and then stepwise stenting or ballooning to the side branch. And actually only 1 patient in 5 requires second stent. And of course, with provisional approach, patients required less number of stents ballooned, less total length of stents, and less procedure time, of course, less radiation exposure, with similar outcomes at 1 year. So we should limit upfront 2-stent strategy in very complex lesions, such as large calcified side branch with a long disease, or sometime when the access to the side branch is particularly challenging. In that case, we should consider upfront 2-stent strategy to save the side branch. Okay. And from how can we predict the side branch compromise before main branch stenting? The one way is look at the angle and distal bifurcation angle of the left main bifurcation. The narrower the distal angle, the smaller the minimum lumen area after main branch stenting. So when you see very narrow angle, then you may think about the something like wire protects the wire. That may not be sufficient, right? Sometimes you need a predilatation or kissing balloon before the stent deployment to the main branch. Another thing we can obtain from the intravascular imaging is to predict the side branch stenosis after main branch stenting. One is a minimum lumen area at the ostium of the side branch, less than 3.7 millimeter square, or plaque burden greater than 56%. So these are only this can be only obtained from the intravascular imaging. And actually the angle, again, is very important when predicting side branch compromise. This is from the OCT study. Actually, the CT angle is carina tip angle, which is shown in this red angle. And the narrower the side carina tip angle, the higher the side branch complication. And again, they also reported that branching point to carina length, which is shown in this one, is also a predictor for the side branch compromise. Okay. And another thing is main branch actually matters, not only the side branch. When you get a calcified plaque on the main branch opposite to the office of the side branch, and when it is reported that when it exceeds 60-degree calcium, you get a high likelihood of side branch compromise because of the carina shift. So in some case, you may consider the calcium modification for the main branch, even if the side branch is relatively healthy. Right? And intravascular imaging can be used to secure the rewiring point after main branch stenting, ideally, the distal crossing followed by kissing balloon is recommended to secure the large osteal lumen without carina, metal carina, residual metal carina. It is called metal carina, neo carina, something like that. And when you use OCT with better resolution when compared to the IVUS, actually you can see each strut and the link between the crown. So based on that, if you want perfection, if you want perfect result, then you can decide the ideal crossing point. And after crossing the wire, you can recheck with OCT and see if it's ideal position. If it's not, you may retry, the crossing the wire and then check again and again. And again, the optimization, this is not limited to the left main. However, like that, because we have to check, the two major predictor of stent failure is, the number one is stent under expansion. And actually for this one, actually the preparation matters. And another one is plaque burden in the landing point. So this can be checked with pre and post with intravascular imaging. So the optimization is again very, very important, not only for the side branch, but also for the stent optimization is very, very important. And actually, a randomized controlled trial, Renovate Complex PCI, this is not for the left main trial. However, they show that the imaging guiding PCI were superior to angiography guided PCI in overall cohort. But when they limited to the cohort to the left main cohort, still, intravascular imaging guided PCI for left main was significantly superior to angiography guided PCI. So I think probably I would say the imaging guided PCI is mandatory for left main disease, especially when it's complex. So take-home message is intracoronary imaging guidance is useful. I would say mandatory at each step in left main PCI. The number one is to decide whether revascularization is necessary. I didn't mention about this in this talk. And number two, to decide stenting strategy, provisional or upfront to stent. And of course, to size the stent and select the optimal landing zone. And finally, to optimize the stent result, to check the stent expansion and position, as well as geographic miss. Thank you very much for your attention.
Yeah, thank you very much. Wonderful presentation, Dr. Nishina. Yes. Now, this presentation is now open for discussion. Any question or comment from the audience or panel? No? Nothing? Just I would like to ask, yes. We have the two modalities, right? OCT and IVUS.
Yeah.
How do you decide which one is preferred?
Well, that's a very important question. Thank you very much for asking. Actually, OCT has one disadvantage because we have to remove the red blood cell with injection of the iodine contrast. So it's not ideal for the osteal lesion. So you cannot check the osteal, geographic miss or position in some cases. So if you are, I think I would choose IVUS if I should choose either one. And especially for the osteal, if the lesion involves the osteal left main, that IVUS will be a better way to use. But for the side branch wiring, if you want perfection, in that case, OCT is still better with much superior resolution.
Okay, thank you very much. Any other?
Thank you. Actually, in our scenario in this country, many of the institutes don't have any imaging modalities. Those who have, they don't use in all cases because of many reasons. One of the major issues is the financial constraint. Other part is also inadequate knowledge about the image because of their knowledge deficiency, many of the things cannot be actually identified. So what is your opinion regarding nowadays the machine has got some other option to see the stent expansion, stent deformation, by like stent booster or anything. Does it has got any role in a place where the imaging modalities is not available, but the perfection of the procedure will be near to the image modalities? Is there any scope of this?
Sorry, I couldn't get your question very well.
The thing is that how can we avoid to use the imaging, but taking the advantage of modern cath lab facilities to near normal imaging result?
His question is, if we use a stent boost, if the under expansion is obvious, we can get. But what about the other methodology to detect
boost,
the information?
Yes. Stent boost is very useful to check the center under expansion or deformity. I agree with that. However, still we don't know if the stent size itself is appropriate for that vessel. So in that case, I'm still stick on imaging for that. Thank you very much.
In my opinion, in complex situation, mostly during bifurcation stent, the imaging modality is much more useful and necessary to see the optimum result. But in normal simple situation like any mid or proximal single vessel PCI, single vessel means that is in a state forward lesion, then stent boost is useful. Even after post dilatation, the former we know that the vessel is to stent ratio 1.1:1. And when we can see that there is some expansion of the vessel wall after stenting, that's also quite informative. But for left main stenting, imaging modality must be used and for optimum result and to avoid complication also. Thank you.
Thank you.
Okay, if there are no questions, yes, thank you very much.
Thank you very much.
Thank you. So let's move on to the next talk. Next talk is coronary bifurcation PCI, treatment of ostial circumflex. My friend, Professor Udin, yes, thank you.
Learned chairpersons from home and abroad, as well as learned audience from home and abroad, Assalamu alaikum. My talk is coronary bifurcation PCI treatment of ostial sarc. Very small thing, very less number of people suffering from this disease, but depth is quite high. Let us see what is the scenario. There are tough questions. How to accurately nail the ostium of the sarc, and how safe is LCX stent protrusion into the left main, floating, meaning that floating stent keeping in left main. Should I touch a healthy LM? And how how to deal with a vast difference in vessel dia. Ostial stenosis in LAD or left circumflex are the angiographic manifestation of bifurcation disease at the distal left main coronary artery location with a variable degree of LMCA involvement and adverse plaque distribution. And findings from IVUS studies show the limitations of angiographic classification and indicates the importance of IVUS for correct anatomic assessment of LMCA bifurcation diseases. Let us see plaque distribution in distal left main disease according to anatomical description 111 Medina classification with plaque distribution. And practically it is shown that 90% of the patients having distal left main disease has LAD lesion also, meaning that left main disease 90% patient have left main LAD ostial extension. And if we see the left circumflex, you see on the bottom right panel, it is approximately 1% if only left main 0, 0, 1, 0, 1. If this happens, then left circumflex is 1%. And if we consider overall, then it is the only sarcostial lesion is approximately 6% of all the left main distal diseases. And you will see the plaque distribution in distal left main diseases. So you come to the, as close you come by 1 millimeter, if you come towards the bifurcation, there will be the increased severity of the plaque. And here see OCT left main in a study of 74 cases. On the right panel you see approximately 001. If you see angiographically it is 12, meaning that 12%, and it has become by OCT only 6%. So we tell that only left circumflex 001 of all the distal left main or involving the bifurcation is only 6%. And let us see the scenario. Disease develops in the low shear stress region, and what are the consequences gradually occurs? Increasing the plaque, anatomically 001, though it is rare, more further increasing, risk of carina shift, trying to nail the ostium. If I try to nail this ostium in a patient of 001, then I may shift the carina, and if I place the stent into the left ostium, I may angiographically miss the carina. And if I come a bit forward, angiographically ambiguity of the left circumflex ostium with the risk of metal carina, jailing the left anterior descending. And to jail half of the vessel is dangerous, as because if there is anything, any disease occurs into the left anterior descending, subsequently there will be no way to enter into the left anterior descending. And if I cover the LAD, it is good, and open with the balloon after carina near rewiring, and it is good, and it is better. Cover the disease using the imaging and check the LAD after, and recrossing the left circumflex, doing the kissing benzoaplasty, and that is the more ideal for a case of 001 or 101. And in one study you see 8,434 patients of bifurcation diseases, and they have seen only 4% of the patient has, 4.1% patient has 001 disease, meaning that sarcostial. And out of this, only 001 patient, you see on the right panel, they have one stent, approximately 60% people, and 40% patient had required double stent. How are 001 treated? And they have shown this. This is the summary of the previous picture. That is, they required out of 364 patients, they required 209 single stent and 136 double stent. Here you consider that approximately 40% of the people having normal LAD or minimum lesion in the LAD or with LCX disease also required second stent. And how common is, we have already told, 2D angio approximately 12 to 15% they show that they have the sarcosteal lesion, and with imaging 1 to 6% only the sarcosteal lesion. And stent across provisional is better, and port case, and after imaging confirmed distal rewiring, and wiring should be rewiring, should be a distal rewiring, and imaging of the sarc and LAD and second stent if necessary. This is the idea. And this is one case. I want to show only 2 cases, as because only sarcostia very soon I have not done many cases. Only 2 cases we have. That is, this patient has chest pain, chronic coronary syndrome patient, and let us see the coronary lesion. Distal left main is involved, but LAD, LCX is also grossly involved, osteoproximal severe lesion, and here the syntax score is 17%. And we have done the IVAS, pullback IVAS from left antero descending as well as left circumflex. And this is the result, pullback IVAS from the LAD and also from the LCX, and it showed that LAD osteal is not significant, 5.6 LAD osteum. This is LAD osteum, this is 5.6. This is LAD osteum, and this is sarcosteum, and this is distal left main. Distal left main has disease, and osteal sarc is critically ill, and osteal LAD is almost disease free. And we have accordingly done left main to LCX stent, and result after this stent, LAD osteum is a bit hazy, and we have post dilated and recross into the LAD, and then we have done the KBI, and we have done finally report. Initially we have done port and report also done, and this is the final result, and this is the IVAS. We have done the IVAS from both LAD as well as from left circumflex, and IVAS picture is not moving. I am stuck. Anyone can help me? I am stuck, I can't go forward. It showed that left circumflex, ostium well inflated stent, LAD is well inflated, and LAD ostium is well. Anyway, I have also another case of similar merit, LCX to LM to LCX, and we have done similarly, and no need for a stent for LAD. To me, to give one stent to the LAD after doing left main to LCX angioplasty and having almost normal LAD is a bit painful to me. And here my boss, Dr. N.M. Mominuজ্জামান is sitting there. He told sometimes with fun that I pray to God that your LCX will close very gradually so that no MI and you will remain all right.
Sir, thank you, sir. May I ask a question, sir, by
Yes.
this time? Sir, did you check for the functional assessment left main to LAD?
Functional assessment before angioplasty?
No, sir. Yes, after angioplasty of the LM
After angioplasty, not only functional assessment, I have done the IVAS pullback from LAD to LM as well as LCX to LM. And
it was okay.
Area is well.
Thank you, sir.
Mir Jamal. Yes, it's a nicely presented one. Very rare, but very difficult to handle. Whatever you're feeling regarding this sort of situation, two things I want to say. The handling the only osteal circumflex at least gives some option for the next operator to handle it safely. Means that if the stent is a little bit in the left main, difficult to cross the next time, because this patient somehow will come back again with some form of disease in the left main ostium, left main distal lesion or osteal. At least if you can cross over, then the next operator can have easy access to LAD.
Yes.
But my question is not for this.
Yes.
My question is that can you use drug-eluting balloon in this situation instead of stent?
Yes, I have also experienced in a different scenario that I have done DK crash for distal left main, one patient. By 6 months, patient has come with restenosis in the sarcosteum. In that case, I have done first with drug-eluting balloon for left circumflex ostium, as because I can't keep the both I can't keep stopping the both LAD and LCX supply for 1 minute, and that is why in a different way 30 seconds 35 seconds keeping the ostium of the left circumflex, and then I have pulled back that balloon and keeping another balloon into the LAD and doing the kissing balloon inflation. This I have done in that scenario.
It's a good technique, because left main, if you inflate the balloon, the patient may not tolerate. In that case, you can pulse it like 30 seconds, then deflate it and again,
Yes.
inflate it again 2-3 times. You can
And
at least
patient
give
is
the
well.
time for deliver the drug. Yeah, thank you.
And my take-home message is isolated left circumflex disease, crossover stenting is preferable, what you have told just now. And intracoronary imaging is crucial. It is important to recognize the necessity of the bailout second stent, if at all necessary. Though in a study, it has been shown that approximately 40% cases it is necessary. And kissing inflation have not been shown to reduce the late lumen loss. In another study, they have shown with kissing balloon, without kissing balloon, MACE is similar in both groups. DCB Barsa award biovascular scaffold could be a good option. More data needed. Thank you.
Yeah, thank you. Thank you, Mir Jamal. May I request the next speaker, Professor Afzalur Rahman, the provisional stenting of distal left main. One stent only. You don't need any introduction for Professor Afzalur Rahman.
Mr. Chairman, ladies and gentlemen, and I always believe, I try to keep my old friend at ease, and I create my new friend. I don't believe that I should away from the old friend and going up more new friends. So I believe that from my inception, provisional stenting is my friend. That's why I am consistent with this technique. Unless there is evidence that something is better documented, then I switch over. Otherwise, I'll not switch over. That is my philosophy of the life. So in my scenario, I will just show you how was I consistent with the provisional stenting. So I don't have a conflict of interest. This is the presentation was given in TCT in the main arena in 2013. The talk was case beginner. In provisional stenting, late main provisional stenting, only one stent. At that time, the metallic jacket was very favorite, and most of the people are using the double stent, triple stent, like that. But I think that provisional stenting should be the standard care. And some of my colleague can see this patient, this is a 108 years patient, profound ST depression, and patient Parkinsonism, CKD, whatnot, everything is there. And you can see the ECG, and I have done an angiogram. You can see that the right coronary is 100% blocked, And left side, distal left main is significantly diseased, LAD is significantly diseased, diffusely diseased, and LCX ostium is also diseased. So I don't think that this kind of the CTO in the RCA is a good choice. So I switch over to the LAD and I go for C. So very simple technique. Everybody is doing that. That is pre-dilatation, adequate pre-dilatation important. Then kissing balloon dilatation, then putting the stent. Then definitely we will finish the port. And this patient was survived for another 5 years and died with the other causes. This is my first presentation. And this is my second presentation in TCT, also in the main arena. Provisional stenting of the distal left main, only one stent. It is 2015. So that was 2013, this one is 2015. And this is the case, you can see that the RC is tightly diseased, and LAD is significantly diseased, LCS also diseased, and tortuous diagonal, big diagonal was there. So definitely RCA is a very durable vessel and simple vessel, so I did the RCA first. Some people think that LAD will do the first. No, here RCA can do that. Because patient is deferred for CABG, we have to go for the PCI. So anyway, we will fix up the left main. This shouldn't be a problem. Then we have done a pre-dilatation and putting the stent, recrossing as usual. Then kissing balloon dilatation port, and this is the final result. And what about in 2024? What is my vision was there? Let us see. And this is another case, 67 years. You can see that the LAD, L6 posterior tightly disease, L6 is disease, RC is also disease. So this is a really triple vessel disease. This may be the right case for the CABG. And we fixed the RCA. And we have done a provisional stenting. We did not do anything with the, we did not put another stent in the LAD. But in this time, I uses the DCB. I did not put any stent in this time in the LCX. Though LCX is significantly diseased and proximal LCX is also diseased, so I did not put any stent. So here I put only one stent, that is DCB in the LCX. So provisional stenting and the LCX. This is the additional strategy in 2024, and also use of the imaging. Port like that and final result, and this is the imaging result. So it is fine. So why I will do the two stent in the first time? Because I can fix up it, and my window is open. You can convert it to dual stent strategy by culotte or tap technique. It shouldn't be a problem. So this is the imaging. So that's why I plotted this figure. That is 2013 provisional, 15 provisional, 23 provisional, 24 also provisional. Only addition to DCB if needed. And also use of the imaging. That's important modularity, especially for left main stenting. Ladies and gentlemen, what is the data we have? What we are doing? Let us see. You can see that in 2009, long before, they said that survival free from TLR is significantly lower in one stent strategy. It is long before. Can you think that? And cumulative incidence of mass is also lower in one stent strategy, 14 and 24. It is published in 2009. And it is another publication, you can see that the TLR is significantly lower in one stent strategy than two stent strategies. And definite stent thrombosis also favor of the one stent strategy. Cardiac death also in favor of the one stent strategy. It is 2011. Think about that. And this is again 2019. You can see that is the second incidence of the, and so one stent versus two stent intervention. So it is definitely better. And what are the other trials? Many trials have shown that lack of benefit associated with the systemic two stent strategies for bifurcation. Nordic trial, BBC trial, BBK trial, Cactus trial, even in patients with the larger true vessel bifurcation, EBC2 trial. Outcome may worse with the systemic double stent strategy. So you can see that even multi-center trial, it shows that systemic dual stent strategy is not superior to one stent strategy. Why will you start with the two stent strategy? But if we consider two studies, one is that the DK crash EBC trial, and my friend Shaolin Ken will present that. He's shown that if the lesion in the L6 is more than 16 millimeter, if it is calcified, larger, he demonstrated that this kind of the patient will benefited by dual stent strategy from the inception. This is the story, this is the very selected patients. Even, I'm sure that even if the patient is non-calcified, if the patient is non-tortuous, if the lesion is more than 16 millimeter, even we can tackle with that DCB. So EBC main trial, 3 years result, you can see that the 1 year result, death and revascularization MI, all in favor of the single stent strategy. Death is also favor, MI equivalent, revascularization also favor in the step provisional stenting. And EBC 3 years target-based revascularization is also in favor of the stepwise provisional stenting. And 3 years, you can see that there is no significant difference between these two groups. So what is the take-home message from the EBC 3 trial? Good outcome at 3 years with bipartisan enlargement stenting PCI. No difference in 3 years. Primary endpoint death MI TLR between the two groups. Almost twice as much as TLR in the systematic dual stent group. Only 20% patient in provisional stenting require a second stent. It is not necessary to decide the number of the stent before you start. The stable provisional stenting is the technique of the choice for the bipartisan enlargement stenting. So my conclusion is that stepwise provisional stenting is logical, reproducible, versatile, and remains the standard strategy of choice for the most bipartisan, including the late main. Approach the late main in a staged manner. It is not necessary to decide the number of the stent before you start. Add layer of complexity as necessary. Stop when you have a good result. End up with a true result only if it is necessary. Thank you, my friend, and thank you. I will take one thing is that if the L6 is large, tortuous, long lesion, tortuous vessel calcified, then you can start with up to 2 stents. Otherwise, always keep on provisional stenting. Thank you very much.
Yes, this talk is open for discussion and question. Any question or comment from the audience or other panel? Yes, please.
I'm Dr. Raza. I fully respect the comments of Professor Rahman. But my submission is that if we go to the definition trial, which was published in 2019, 2 years data, I think that is, we know that more than 70% of the patients, they get away with single stent. The data is very strong in this favor. But with regards to definition trial, it's only that small portion. I agree that it's the majority of the patients, 1 stent is fine. But 2 stents, by definition, to select those patients who really get benefit of 2 stents, that is a little raise a question mark. But anyway, thank you for your presentation. This was wonderful. These are my comments. Thank you.
Any comments?
Observe. So practically, if the vessel, both the vessel is almost 3 millimeter each, then in that case,
is both the vessel equal size?
They are 3 millimeter, more than 3 millimeter.
Yes.
Then in that case, even
no,
the distal left main.
Yes, that's a good question, I think so. If the vessel is 3 millimeter, or 1 is 3, 1 is 4, whatever may be but significant size L6. But L6 is an ostial, not long, non-calcified, and also non-tortuous. I think so we can start with the provisional stenting, and we have a good DCB. But if we afraid that crossing the L6 from the LED, it is very difficult after something happened, or if calcified or tortuous, predilatation, you can have a dissection, or after imaging, you think that how far the LCX is dirty. That is the decision.
I think.
So do the imaging first. Do the imaging first. If the imaging is available with you, then take a decision. But don't take a decision before convincing you that this is necessary, absolutely necessary. That is my thought.
You're right. Basically, the left man with a left dominant system, you don't have any other choice other than use two-stent strategy. In that case, do you prefer to have a professional stenting in a patient with left dominant system?
No, you are telling me that LCX is dominant.
Yep.
And LAD is non-dominant.
No, LAD is dominant.
No, that's fine. That also, I will convince, I have to convince that how far the lesion is severe, how far is the length. Length is also important factor, not the, if it is 4 or 5 millimeter, then you can fix up with the DCB if the non-calcified.
No, I'm telling you, it's the left dominant system.
No, I think sir is giving more emphasis that the LCX territory is
okay, you are
bigger.
insisting me to push on the double stent strategy. That's fine.
Yeah.
If the LCX is dominant, if the RCA is non-dominant, then you can think about that. But before that, you should consider about the length of the lesion, calcium of the LCX, torsiosis of the LCX, and you do the IVAS and take the decision. Sometimes the LCX seems to be significant, but after doing the imaging, you will see that it is not significant. We are frequently see such kind of thing, especially on the osteal. I am not denying that we should not go for double stent strategy. I am in favor of the two-stent strategy in some circumstances, but we have to clearly define that. We have to clearly convince that. We have to clearly evidence that. That is my argument, nothing else.
Thank you. Actually, there's a common practice we are used to do the provision of a single stent strategy is good than the double stent strategy. Thank you. I think we can proceed for the next.
Okay. So let's move on the final talk. This session keynote lecture, DK crush stenting technique, past, present, and future. This will be presented by Dr. Xiaolian Chen. Dr. Chen is here. Yes. You should be.
Oh, perfect.
Yeah. You are mute, right?
No, I don't think so.
Yes, we can hear you very well. Yes, please.
Okay, thank you. Yeah, first of all, I appreciate the invitation by Professor Riemann and the BIT organizer. I'd like to present a DK course to follow the workflow from the beginning to update. So actually, among PCI patients, most probably bifurcant lesion varies from 20 to 40%, depending on the different definition of bifurcant lesion. For any kind of bifurcant lesion, I think the hot topic is how to select the stenting technique. But the key problem is that to minimize the intra-procedure complication, particularly to try to avoid the occurrence of side branch occlusion, which always happen around from 7 to 20% according to the previous published several trials. I think one most notable trial is the COPS-2 registry trial from the South Korea to report the high rate side branch occlusion during the provisional stenting technique. And for any patient who experienced the side branch occlusion, would have high rate of MACE, including death, myocardial infarction, and revascularization. So in almost 2000, Dr. Colombo, Antonio Colombo, reported the first modified T-stent technique called classic crush technique. Nowadays, we call it classic crush technique. Dr. Colombo team reported only 40 patients after classic crush technique, but the final kissing balloon inflation was only performed for 70% of the lesions. So I think this is a key problem. Why there is so low rate of successful final kissing balloon inflation? Next, how to improve promote the quality of final kissing balloon inflation. So previous study have reported, I think probably the independent factor to predict low rate of final kissing balloon inflation lies in the 3 years overlapping of metal struts. Also, I think this finding is also the driving force even now today to avoid multiple stent for coronary bifocal lesions. On the other hand, at the same time, almost we start from 2004 to test the new concept of decay quality stenting technique. I think the big difference between decay and classic quality technique is the introduction of the first kissing balloon inflation immediate after stenting technique. I think this is the key difference between two stent techniques. Again, let's back to the EBC classification for giving a classification of Medina bifocal lesion. So usually we can start from a vessel. So this is called standard of prominent stent technique. But the thing that prominent stent technique does not mean one stent technique. It could be shifted to two stent technique if second additional side branch stent is required. Second strategy is studying from the side branch, including classic quash, Kulos stent technique, or even decay quash technique. So I think we still need to do more tests to compare different two stent technique. Firstly, in 2004, we reported our first serious feasibility study of decay quash technique. We only included 20 patients with true coronary bifocal lesion undergoing decay quality technique. Finally, kissing balloon inflation was performed in 100% of patients. I think this is the first report from mainland of China to compare decay quality with a classic quality technique. After that, we designed and conducted our first decay quality 1 trial to compare decay quality with classic quality with the implication of the clinical endpoint as a primary endpoint. It was a MACE at 8 months. So if you study serially a previously published clinical trial, so most of the primary endpoint from those trials was a short-term clinical follow-up. Even the clinical endpoint was the primary endpoint. In our decay quality 1 trial at 8 months follow-up, so the MACE rate was 11.4% in the decay quality compared to 24.4% in the classic quality. I think this is the first report. Simultaneously, we also report why there was so high rate of MACE of the classic quality because of very low quality of kissing balloon inflation after classic quality technique. After that, we need to compare decay quality with a prominent stenting technique for a non-left main coronary bifocal lesion. We included 370 patients. The primary endpoint was also MACE, but it was defined at 12 months follow-up. So by 1 year follow-up, it was 6.5% in the DKN compared to double increase in the prominent stenting technique as shown in the right panel. You can see the two curves separate each other after 4 or 5 months. So also from our previously decay quality 1 and 2 trial, we can conclude that the separation of two groups, I mean decay quality with the classic quality or prominent stenting technique studied after 4 or 5 months. So this is why we need to design our clinical trial to extend our clinical follow-up until to minimum 1 year. Again, we designed our decay quality 3 study. I think this is a very important trial to show how much benefit a patient can get from decay quality technique. But before that, we need to extend our clinical follow-up of decay quality 2 to 5 years. From the figure, you can see two curves separated each other from 1 year until to 5 years. This is the most long-term clinical follow-up for decay quality 2 trial. After that, our DK-3 study compared DK and Provenance and the Kulos technique for distal left man, only distal left man bifurcal lesion. This is a very popular compared with a EBC man or DK-5 trial. So I think the major finding was very consistent with the European report about the long-term clinical follow-up after Kulos technique. There was a high rate of stent thrombosis, raising concerns about the long-term safety of the Kulos technique for distal left man bifurcal lesion. There was no surprise. We also extend the 3-year follow-up for DK-3 study. So I think both the 3-year and 1-year clinical follow-up confirmed the benefit of DK-3 for distal left man bifurcal lesion when compared with the Kulos technique. DK-4 study is our another pilot study. We tried to get the immediate change of FFR immediate after DK-4 or Provenance technique for patient with coronary bifurcal lesion. The main result was a driving force to design our next DK-6 study. So this is a brief summary of DK-5 study. I think it's a milestone trial to compare DK-5 with the Provenance technique for only distal left man bifurcal lesion defined by Medina 111 or 012 true coronary bifurcal lesions. So from the Kaplan-Meier curve, you can see two curves separate each other immediately after the procedure. I mean, after 48 hours. It's because very high rate of tidal vessel myocardial infarction or pre-procedure myocardial infarction of the Provenance technique. Provenance technique is effective for most greater majority of bifurcal lesion, particularly for simple bifurcal lesion. From this trial, from DK-5 trial, we tried to classify patients, stratify patients into simple and complex bifurcal lesion based on our definition criteria. Obviously, very high rate of MACE at 1-year follow-up after Provenance technique for patients with complex bifurcal lesion, non-significant difference between two groups for patients with simple coronary bifurcal lesion. I think this is very, very important. Also, we provide a 3-year follow-up for DK-5 technique. So from the figure, you can see we also provide the yearly increase of MACE after DK-5 or Provenance technique. It was a 1.7% increase after the Provenance technique compared to 1.2% of the DK-5 technique. So I think on the left panel you can see if there was no significant difference by landmark analysis between two groups. So we had to do our best to minimize, to reduce the MACE rate within 1-year follow-up. I think this is a key finding from the 3-year follow-up of our DK-3 study. Again, when patients were classified by syntax score, nurse score, our definition classification, we have to particularly pay more attention to patients with real complex coronary bifurcal lesion. This is what I said DK-5 study. We tried to compare angiography guided compared with the FFR guided side branch Provenance technique. Flow chart showed immediate after stenting main vessel. If there was severely pinched side branch, we need to measure FFR in FFR guided group. But in the angiography group, we don't need to measure to assess the function importance. At 1-year follow-up, MACE rate was non-significant difference between two groups. But in the FFR guided group, there were less frequent, less number of second stent in the side branch compared to angiography group. Second point is that because, after stenting main vessel, somewhat it will be very difficult to pull the pressure wire into side branch. This is the key problem to limit the generosity of the DK-4 trial. DK-7 study is another trial to try to identify the cutoff of post-procedure of FFR to predict long-term clinical follow-up. We provide different cutoff value of FFR for RAD, symphylis, and RCA also. So for lesion localized in RAD, post-standing FFR less than or equal to 0.80 to 8, strong predict long-term target vessel failure during the 1 and 3 year follow-up. DCAP-QASI-A trial is ongoing. So last December, we just finished the last case enrollment. After 1 year, I think in the 2026, we will report the 1 year clinical follow-up. The trial was designed to compare IVUS-guided with angiography-guided DCAP-QASI technique. That means we only include patients with real complex coronary bifurcation lesion based on the definition criteria. Patient number was 556 patients. So let's open our eyes and wait the final result. Based on our previous study, we have found the general consistent finding was that DCAP-QASI was a beneficial patient, particularly with a complex coronary bifurcation lesion. So this is why in 2015, we proposed our definition criteria, and based on it, we designed our definition 2 trial. It only included patients with a real complex coronary bifurcation lesion. For example, lesion, side branching lesion length minimal 10 millimeters, 90% a baseline diameter stenosis for non-left man, but 70% for left man bifurcation lesion. I also provide 6 minor criteria, 1 major, plus any 2 minor criteria. So lesion could be classified by complex bifurcation lesion. Paper finally was published in the European Heart Journal. So from the figure, you can see by 1 year follow-up, the TLR, tidal vessel myocardial function, were significant differently between two-stent technique and the provenance stenting technique, leading to the final very high rate of tidal lesion failure in the provisional group. In the two-stent group, almost 80% of two-stent approach was a DCAP-QASI technique. So this is why in the discussion section, I boldly say I'm very, very confident, very trustful to use DCAP-QASI for real complex coronary bifurcation lesion. So again, we provide a 3-year follow-up similar to the final finding, 3-year results for the DCAP-QASI 5 trial by landmark analysis. So we also provide a very significant difference between a post-procedure to 1 year follow-up. But after 1 year follow-up, actually there was no significant difference. So this is why for any given bifurcation lesion, we have to do our best to minimize the 1 year miss rate. Also, Dr. Jura reported the meta-analysis, including 21 randomized trials with 5,711 patients with individual different kinds of bifurcation lesion. The final result included the side branching lesion length minimal 10 mm is the first predictor of long-term clinical outcome, clinical events. Secondly, from the figure, you can see when QASI, DCAP-QASI T or top technique, including the trial, only DCAP-QASI showed the benefits for patients with real complex bifurcation lesion. Similarly, the same group provided another analysis to show individual comparison of the TLR, tidal vessel myocardial infarction, MACE, also the tidal lesion failure. So finally, in the remaining several slides at here, during DCAP-QASI technique, how to do troubleshooting, how to overcome any technical problem. So for the first case, RAD diagonal, after pre-dilation of RAD, and also diagonal. So, after finished the two-stent technique, so the cross of balloon into the diagonal could be difficult. But one technique is that we can rely on the balloon anchoring technique. This is second case after decaquation technique, after selenium decaquation technique, we also need to rewire side branch. So we have to very carefully to make sure the wiring position also from the proximal cell of side stem. This is the key. This is crucial for the success of the decaquation technique. Third point is that immediately after slitting side branch, right now we highly recommend to do proximal side branch optimization. It means we can use the stem balloon or another NC balloon to post-dilate the protruded side stem in the main vessel. This is very important. My great friend, Dr. Francesca Lavara, has published his first paper to show how important of the PSO during decaquation technique. After staining both vessels, so pour should be done, but should be done in the right way. It means the proximal distal should be as short as possible, not to extend distal to the bifurcation groin. And also we need to keep the proximal shoulder of the balloon within the proximal edge of the main vessel stem to avoid the occurrence of dissection. Once again, for decaquation technique, if a balloon could not be crossable to the side branch, we can use the anchoring technique. Also, we can use the guidelizer. But the precondition is that the side branch wire should be from the proximal cell of side stem. So finally, ladies and gentlemen, in conclusion, we have greater than 20 years of decaquation clinical trial experience. We have very large database. We have different subgroup analysis to support the benefit and the importance of decaquation technique for real complex coronary buffer condition. Now, right now, I think in China, particularly in China, so decaquation is very less used for simple coronary buffer condition. Only used for patients with very long side branch lesions. So probably another point will be some guy could be in different way to say probably we can use drug pulling balloon for side branch for incomplex bifurcation lesion. But so far, except for our DCB BIF trial published in TCD last year, I think so far there is no any clinical evidence to support the DCB use for patients with the real complex coronary bifurcation condition. Thanks for your kind attention. Thank you very much.
Thank you very much, Professor Chen, and congratulations on your continuous study in the DK crash, right? And now it's DK crash 10, right? Great data. So
Thank you.
Yeah, I would like to just confirm. You just talk about a complex bifurcation region such as Medina 111 or 011, right? At that time, DK crash is the best, right?
Yeah, actually, I agree, but not fully agree with your comments. Actually, the Medina classification 111 or 01 are two true coronary bifurcation lesions, but it did not provide the complexity of bifurcation lesion. Thank you.
Any question or comment? Yes, please. Wait a moment. Yes.
Thank you.
Hi, Professor Chen. Dr. Afsar Raza here.
Hi, Afsar.
Yeah.
Good to see you. Good to see you.
Thank you. One question that you mentioned about the future of DK crush. May I have a humble submission of the biodegradable stents, because the main problem is the crushed part in the carina. That is the main problem that cannot be resolved with metal stents. We know that the biodegradable stents have not been a good news in the past, but what about the future if you improve the biodegradable stents and they get resolved after, you see, making the geometry and with free of any metal work in the carina? Thank you.
Thank you, Afsar. I think So far, our DCAP-9 trial is ongoing. Another Chinese colleague team is comparing DCAP and prominence standing technique for simple distal left main bifurcated lesion based on definition criteria. Next point is the answer for your question. For convention BVS or BIS, I think there is no any room left for the use. But right now in China, there are new platform. So it's a mixture of BVS with DS. That means the middle segment is a biodegradable stent. But as a proximal, the distal probably 2 millimeters or 3 millimeters in length are DES. So it could provide the ability of overlapping to any two stents for diffuse lesion. Also, if we use this kind of new design, combined DS and biodegradable stent, we can do decapitation technique because the proximal 2 millimeter DS could be protruded into the main vessel. Thank you.
Any comment or questions? If not,
Yes,
thank you very
hello.
much, Professor Chen.
In very nice presentation and a lot of information we have gathered regarding decay crash. But many things evolved in interventional cardiology and many new things also coming. And the earlier days we used to use debulking technology, especially directional atherectomy. In earlier days in 2006-07, we also uses bifurcation stent. So we are badly needs new development of bifurcation stents to avoid all these tough bifurcation procedures. So Professor Chen, what is your opinion regarding, is there anything going up with bifurcation stent in the market?
Oh, thank you for your question. I think debulking technique is not stenting technique. It's a technique to prepare a lesion before stenting. So, we also frequently use the directional atherectomy or a shock wave or any other, for example, cutting balloon or scoring balloon to prepare a lesion to make sure the stent could be fully expanded. Secondly, in terms of the bifurcation dedicated stent, I think after 2017, all these stent bifurcation dedicated stent have escaped from the main stage, from the podium, because very high rate of incident restenosis. Thank you.
Yes. Thank you again, Professor Chen, a wonderful keynote lecture. It's a time to close this session, and I would like to say we have 4 important presentations about the left main bifurcation. And initially, I think angio-based diagnosis is the base, but recently we have an imaging and also the physiology, so result is improving, and especially the bifurcation lesion treatment, we are focusing on only technique, but also we have to know the real anatomy by the imaging. It might be related to the result. Therefore, for all presentator, always emphasize the importance of imaging, and Dr. Chen also emphasize the physiology as well. Therefore, for the bifurcation lesion, I think imaging and physiology should be important things, and your decision should be depend on both technique. This is my conclusion. Thank you very much, everyone.
Yes. Yeah.
Hello. Helen, did you connect?
Yes, yes, I am connected, but I would like to be in diaporama mode, and Martin tells me that it's not in diaporama mode. I see it on the screen. Je sais pas comment faire, Martine.
Pourquoi tu es...
Bah, sur mon écran, c'est en diaporama mode.
Et là, tu n'arrives pas à cliquer là-dessus. Peut-être éteins-la et remets-la, rallume-la.
Et avant de partager, est-ce que je me mets en diaporama d'emblée?
Non, non.
Je me mets sur la première simplement?
Oui, oui.
Bon, alors attends, je recommence. Partager. Tu as rien?
Bah, c'est toujours... En fait, nous, il faut que tu quittes le partage et que tu refasses le partage.
Bah, c'est ce que j'ai fait.
Voilà, maintenant vas-y, refais. Et mets-toi maintenant en diaporama.
Bon, je vais appeler Claire. Tu veux dire un petit mot ou je sais pas?
Yes. So we have Hélène has some difficulty in order to have the mode, diaporama mode. So she called to a technician in order to help her to deliver this very important tribute to Alain Cribier. So it is a pleasure for me to be with you, and it will be better to be in presential, but it's impossible this year. So I am very happy and honored to be to share this tribute with you in the BET Summit, which is a very important meeting, as I know.
Okay. Mamas, can you tell something because there is some connection difference?
So thank you, Martine. It's a pleasure to see you, albeit on the screen rather than in person.
Yes.
We understand that you have IT problems over there, so we're eagerly awaiting. But we have a great panel here. Perhaps we can go along the panel and introduce ourselves. So you know me.
Sophia Rahman is here. Rihanna is here. Can you tell something about Alan, Professor Sophia Rahman?
So please introduce yourself.
Some of you know me and some of you don't know me, but I'm Professor Dr. Sophia Rahman, who has started the intervention in this country.
Yes, we know you. We know you.
Yes, no, I know you. So we started the intervention, and I with my team and our patient, totally without any help, but the help was there to train us. And after training, when we started flying, and that time we could do all these things. First, when I met him, it was in Paris. First time we went for training there, and at that time I was trained for intervention that is for angioplasty and putting stent. But his interest is how he started first, and then he took me, and then at time Professor Letic was also alive. So some of you probably know there's an aortic balloon, Alan Letic balloon, which we used to do aortovalvoplasty. So I have seen both the giants there, both the scientists there, and he is always like that and restless. What is after? What is after? How to do it? So not only they have invented the balloon, they have ended up having a aortic valve replacement percutaneously. That is also, this is in NICVD, and this is not my collection, it is he collected it and he has produced it when they have honored him in 20 years of his life in this field. And I was so lucky that he called me there also. Sophia, you must come. I didn't want to go. I had some other problem. He said, no, I don't want to say, hey, you must come. And I was the one because he called all the people in his first 20 years of his interventional life. And I was, after that, I thought, if I wouldn't have gone there, I would have missed it. So there they were telling how he went for this aortic valve replacement. He went to several engineers, he went to several people, several scientists, and nobody was buying his idea. But ultimately he did. He was successful. So when we went there first time, I started, I said, I want to do the aortic valve. He said, that is the most difficult procedure of all the procedures you do. So then he invented the metallic mitral valvotomy device. Then he said, do one thing, we'll do a multi-center study, you start that. So I said, okay. That's why he came in NICVD himself, brought all things and they donated to, not in the, in the hospital, because they were not recognizing even my procedure, how they will take the instrument. So he left it with me, and then we went in the cath lab, and you have seen the picture, it is from his collection. And that time, Professor Turi also came from America with him to see how the metallic valvotomy valvoplasty can be done.
Yes.
Helen, Sophia,
So
given you a lot of trouble when I was there, but we are really grateful to him than what he did and where we are now today with intervention, is unbelievable. So after that, I continued. I sent the papers, and that way I learned how the multi-center procedures can be done and collected and presented. So that was our role from Bangladesh, and he was never ever negative with anything. Always will push you to do something if you can do it. That way, when I was doing all these things, one day Professor Afzal came and said he wants to go and train in there. Can you introduce me with him? With pleasure, because I know Alan, he will never say negative to anybody. He's always encouraging people to do the intervention. That's why then with the introduction, then he wanted to go, and then Professor Afzal said, I don't want to go for short time, I want to go for real good time so that I can get proper training. And then Helen was there, and Professor Allen was there. He went there, trained himself. After that, from our country, also you went there for some time, very short time. Lot of other senior professors gone to see the center. Okay, I'll talk again. Okay, thank you very much.
Thank you
Alan,
very much.
thank you.
Due to shortage of time, because the next session is also online, so they might be on the, they might be waiting for that. So, Helen, can you start your talk?
Yes, of course. Okay, so thank you very much, and I apologize for this technical problem. So I'm very pleased to be with you, as was said by Professor Gillard. I came to your place several years ago, and Alain Cribier went several times to your place. And here, as you said, there is this nice picture of Professor Afzalour with Alain Cribier and Toury, from the guy from America who came and who trained also, and who was very expert in mitral disease. So the first to be connected with Alain Cribier, I guess, was Sophia Rahman, and then we had Afzalour coming to our place for a long time, and we kept very good connections with your place, with your centers, and with the country. So I have several pictures I like with Sophia here, and thank you, Sophia, for coming 2 years ago to this big event we organized with Martin Gillard for the celebration of the 20th anniversary. I can tell you that he was very, very happy to have this celebration. He enjoyed it a lot. He made many pictures, and I have a few of them in my office. It was for him a great honor and to have a great pleasure to have all his friends, his colleagues from all over the world in May 2022 to celebrate this. And here you see both of you, Afzalour with Alain Cribier, and in fact Thomas Cuisset was there, and I guess he's in the next session, and he enjoyed to be with Alain Cribier, with you, and he spent a very good time there, and he had the opportunity to have a good connection with Alain Cribier, who is his partner in France. So I will start my tribute to Alain Cribier just to tell you that probably you don't know, but when he was a student, in fact, he was hesitating between piano and medicine because he was not only a doctor for the last 50 years, but he was an artist. He was always playing piano at home every day, and it was a big hesitation, and he was a great pianist. So all of you know him for this invention, the concept of a non-surgical treatment of aortic stenosis. That's why probably everyone knows him. And you have here the pictures of the first in man, which was done in April 2002 with Christophe Tron, myself, and Alain Cribier. And you see the patient who got a valve, an aortic valve, on local anesthesia in the cath lab, which was the concept of Alain Cribier to make a procedure which was like a stent-like procedure, and we're almost there, having this patient treated on local anesthesia and discharged the following day. So Alain Cribier, what is his initial story? He was born in Paris, he went to medical school in Paris, and he moved to Rouen, you see where it is, close nearby the sea, 100 kilometers, for his residency. And his chief was Brice Letac, who was at that time already a kind of pioneer because he sent Alain Cribier to the United States for a fellowship, and he sent him to a famous place, in fact, it's in Los Angeles, to the Cedars-Sinai Center. It was a famous place because you recognize the names, Jeremy Swan and Willie Guns, the famous Swan-Guns catheter. And there, in fact, he got this research spirit, that he was always saying that he got the spirit to do research, in fact, to solve a medical treatment, like an unsolved clinical problem, and that's the goal of research. And when he came back to Rouen, A few years later, he met again. He was very happy to meet once more Willie Gans, you see at the old age, and he said to the son of Willie Gans, "Your father will remain forever in my heart. Knowing him and working with him had been one of the most important events in my life because he gave him the spirit of clinical research." And when he came back to Rouen a few years later, and he was only 40, so very young, he met this first unmet clinical need. He was facing a patient who was 72, very symptomatic, with iterative hospital stays, and she was refused by the surgeon for surgery because they said she was too old, and he decided, I have to find a solution. And he used the balloon used for pulmonary congenital disease, and he did the first balloon aortic valvuloplasty in an adult with a calcified aortic stenosis. You see here the balloon, you see the result. It was a great success, a clinical success for the patient, because the patient remained asymptomatic for a few months and even years. And this publication was very important for the cardiology community, published in the Lancet, and led to a great enthusiasm in the field of cardiology. But at the end of the 80s, you know that we had to face the fate of restenosis, because there was like a kind of recall. And that's where he demonstrated his sense of observation, because he wanted to find a solution. And his observation came from the fact that the balloon could always be circular during inflation, meaning the balloon could push aside a very calcified valve despite the volume of the calcification. And he had the idea of thinking, if we can maintain open the aortic valve after balloon valvuloplasty, we can put something like a metallic structure and adding a bioprosthetic valve inside. And doing that, of course, using regular percutaneous technique on local anesthesia, and this was really this incredible concept. And for more than 5 years, his leitmotif was, I need a prototype. And it was, as you know, impossible to convince a company, anyone in France, in Europe, in the States, because nobody could believe it would be feasible. He couldn't find a prototype despite drawings. You see here these drawings, who are exactly what we are doing today with balloon expandable devices. It was not more convincing. We did in Rouen with our surgeon a homemade prosthesis, which was a very important step, because we could demonstrate that by reducing the size of the stent over a balloon, it could be introduced in a vessel around 8 millimeters in diameter, so in probably half of the patient, in adult patient with a femoral artery, which is about 8. And also a major step was the proof of concept in cadavers, when you see we could demonstrate that the stent could fit exactly below the coronary ostia, above the mitral valve, above the septum, and it was feasible to maintain it in place without damaging surrounding structures and being well crimped in the calcified aortic valve. So something changed in 1999. So you see, almost 10 years later, when he met two engineers, Stan Rowe and Stan Rabinovich, and they decided, all three, to create a startup company, and then asked Martin Leon, the famous cardiologist in the United States, to join them to create a startup to be able to try to develop a prototype. And that's what they did. They found a small company in Israel with this engineer, Asaf Bash, who did the first prototype. You see it in his hands. This is the prototype. And really, Alain Cribier was really had a huge recognition for this engineer, who was the first to say, it's feasible and I will make it. And finally, I have to go fast, of course, first in man was done, and you see the extremely impressive result on a patient who was on local anesthesia in the cath lab, so something never done. The valve was implanted, and there was no more aortic stenosis. So it was absolutely incredible. And you know that in that case, we had to go transeptal, but it was absolutely not the initial goal. It had to be done like a stent-like procedure. And this is the patient with Alain Cribier, and the following story of TAVI until next guidelines, which will come next summer. So Alain, for that, received awards all over the world and recognitions. At the ESC, in Paris, at the Le Foulon de la Lande Academy, at TCT, everywhere. You can see here different prizes. And the last one was the title of Doctor Honoris Causa of the National Academy of Medicine, which is, Martin is a member of the National Academy of Medicine now. It's the Doctor Honoris Causa. We have only 7 physicians in France over the last 250 years, and 4 of them got the Nobel Prize. So imagine the level of being accepted as Doctor Honoris Causa. Then something which is important is that Alain Cribier, in fact, was an inventor from many years before. Beyond TAVI, he developed several innovations, and not everyone knows about that. In the early 80s, he was one of the first on doing intracoronary thrombolysis. He did many publications. In 1988, in fact, it was my medical thesis, he developed a coronary stent, and also he invented the rapid pacing, which is so much used and is absolutely necessary in all the procedure of balloon expandable and also for balloon dilatation. And of course, you know that because the first place to use this innovation, which is a metallic percutaneous commissurotome, was in India with Pratap, and of course he traveled a lot in India. He took me also to India. I went myself, and we could proctor the use of this incredible percutaneous device to treat patients with mitral stenosis. And the goal of this device was, of course, to be efficient, but to be metallic, to be reusable, and to be like the Dubost surgical device, so being very effective, and thousands of patients could be treated all over the world with this device. You see here a picture in Dhaka. I don't know if you have that, but it's very impressive. You have all these people watching, and your device is in the hands of Alain Cribier to treat the numerous patients with mitral stenosis in your country. But above these innovations, which is something, of course, which is known by all the medical community, he was, as you said previously, really a humanitarian person. He was beloved by his patients. He was very simple. You can see he is sitting next to a patient, we're just discussing with her, here dancing after her procedure, very close, always giving hope to his patients, explaining everything to them and to their family. And I still have patients who each time ask about Alain Cribier and tell me how impressive he was as a human aspect of this man. He was a teacher, and you know that, again, this picture, always wishing to explain, to demonstrate, to make people better, giving advices, and he traveled all over the world. We organized meetings in Rouen. He really was never tired to go everywhere. He was at the origin of the medical training center in Rouen, which is a huge building with everything like transmission, cath lab, simulators, and he's at the origin of this building. He was, as was said, also a very hard worker, and I always remember when we're going to India or to Bangladesh with him, he will always accept, even at 8 p.m., to do another patient or to give an additional lecture. Really a hard worker, always working at night in the weekend. He was always very proud of the team in Rouen, and it was very nice of him because he was always saying that he had the chance to work in such team because we were, of course, with him at the time where he had a lot of opposition. And that's true that we were like a family for him, always supporting and helping and of course, supporting all his ideas and applying them even at that time when it was difficult, when TAVI could take 3 hours. He was very enthusiastic, always with his this joie de vivre, you can see here, always with his incredible smile, always happy, and something which is important, very enthusiastic. After each TAVI, you see he was used to kiss us, because each time was like the first time, even though it was after 1,000 or 2,000 cases. So I finish with this picture I like very much, because he had this, I guess, I would say this legendary smile, this allure, this style, with his, when he was working, we could recognize him from 100 meters. He was very nice to everyone. He was a mentor for me, of course, and he gave inspiration to hundreds and hundreds of physicians. So thank you.
Okay, thank you, Professor Helen, for a nice demonstration. And actually, due to shortage of time, we are going to at the end of the talk. I think so. Can I request Gilbert to give a closing remark, because my friend Thomas Crusade is waiting for me. But Helen, when we build up the program, I think so we have to give more time, more window for this session, because we have a lot of the people are waiting in front of me. The whole room is crowded because everybody in Bangladesh likes Helen Kebrier. Can I talk to can I request Gilbert to close the session?
Yes, so thank you so much. So for me, I would like to thank Hélène for this great tribute from Alain Clivier. For me, he's the greatest cardiologist of the century. He invented, defended, and achieved a revolutionary treatment while remaining, as Hélène said, profoundly human, generous, with no bitterness, an ever-present sense of humor and a luminous smile. I am so fortunate to have been able to be close to such a great man. And for me, we never forget him. I think he's always with us. Thank you so much, Hélène.
And thank you very much, Gilbert and Helen, for excellent presentation and sharing your experience with Helen Kebrier. And we cannot, nothing is lost more than that. So thank you very much. Thank you.
Thank you.
Thank you.
Hello, my friend. This is a very exciting session and also important session. Can I request Dr. Nesser and come here to moderate the session and call the other discussion and panelists?
Thank you, Professor Afzalur Rahman. I'm Nasser Khan. I'm an interventional and structural cardiologist and the program director of cardiology fellowship at Methodist Dallas Medical Center. So for the sake of time, we are going to be, I will request all the speakers here to be on time for our next session. It's going to be a hybrid session on aortic stenosis and TAVR. And we have Dr. Thomas Quisette online. Our discussants here, Dr. Mominur Zaman, Dr. Muhammad Badiu Zaman, Dr. Kasa Nasrullah Khan, Dr. Chandramani Adhikari. I would like to request them to come here if you're here, please. And we will start with the Okay, thank you, Dr. Mominur Zaman and Dr. Adhikari. Do we have Dr. Kasa Nasrullah? Okay, we have online Dr. Nicholas Dumontel joining us. And I would like to request Dr. Thomas Quisette to start his opening address. Can we have Dr. Thomas Quisette online, please? Can we connect him?
Yeah, can you hear me?
Yes, we can hear very well. Thank you so much. Yeah, we can see you as well. Please start.
Okay, it's good. I would just like to share my screen very briefly. I don't know if you can see it now. Yeah, I'm sure you can. So today with Nicolas, we are very happy to join you for this joint session on behalf of the PCR board and EuroPCR course director. We are really happy to connect with the BIT community, with friends from Bangladesh, India, and beyond. And just on personal note, I just wanted to share this slide with you because a few years ago, and it's really a good link and transition with the talk from Hélène, because I had an amazing memory in Dhaka with Rabin and with my friend Afzalour, as you can see on the slide. Because as of today, it's still my first life case that I did in my professional career in the public institution in Dhaka, and honestly, that will stay in my head, but even more in my heart for the rest of my life, because the people I met there and the meeting I've seen was absolutely amazing. So we are very happy to be connected again today. I would love to be with you in Dhaka and together with Nicolas, but of course, as you can imagine, sometimes it's difficult to travel too much. So instead, we are connected today and very happy to share practice with people from the region. And without further introduction, it's my great pleasure to welcome the first speaker to discuss and to see the different practices about the difficult decision in patients with aortic stenosis. So please, it's my pleasure to welcome the first speaker.
Thank you so much. Now I would like to request Professor Afzalur Rahman. He's going to talk about a case, his TAVR patient with high risk of left main coronary ostium occlusion. And then after that, we would ask Dr. Nicholas Dumontel online to make his remark on how he would deal with the case. So with that, Professor Afzalur Rahman.
Okay, thank you very much. I did not lot of the TAVI cases, but within this time, I faced a difficult situation in a patient, TAVR patient with a high risk of the left main coronary artery disease. So I will present the first part of the case. And this lady is 75 years, and many comorbidity and severe aortic stenosis. You know that PPG is 75, mean pressure gradient 47, aortic annulus was 18. He is an absolute normal will function and moderate concentric LV hypertrophy. And due to the age of the patient, comorbidity surgery was declined for the patient, and the patient is relatively very aged. This is the echo gradient. You can see that the echo is a significant gradient shows in the echo. And we have done CT angiogram. We can see that the aortic annulus, annular diameter is 15, and maximum is 58, and average is 18. SOV diameter is 23, and then sinotubular junction is 22, and LV OT diameter is average 17, and root angle was 43. And most important thing is that if we see that the coronary ostium on the left side, it is 7 millimeter. So it is very challenging time that how we can handle this case. So 7 millimeter of the height only, usually normally is more than at least 10, but usually more than 30. But here is 7. So in the 7, the chance of the coronary ostium is get, and sinotubular and sinus valsalva was not. And with this, so low set coronary artery in the aortic in these patients. And then there is some calcium, not really big calcium, and valve to coronary distance is only 3 millimeters. So this is really a high risk case for TAVR. But we asked the patient for several times that something has happened wrong. We can discuss with the heart team, with the surgeon and the patient, but surgeon is declining for the surgery, and patient company and his relative also declined for the procedures. So we should proceed on the TAVR, but the difficult, how should I do? Which valve should be appropriate for this case? What are the measures we can take for preventive or if acute emergency is arising? This is the question, and I am put this case in front of you that how we can handle it. Thank you very much.
Thank you, Professor Afzal Rahman. So as you can see, the challenge is if you put this is a great case for TAVI valve, but the question is if you put a valve, are you going to occlude the coronary ostium? So I would like to invite Dr. Nicolas Dumontel to share his thoughts on this case and how he would like to tackle this case. Can we have Dr. Nicolas Dumontel connected online?
I'm not. He is.
Can you hear us? I think we can see you.
Nico, you're on the screen.
Yeah, sorry, I lost the sound. So can you hear me well?
Yes, we can hear you, and we can see you as well. So it's your turn now to give your comment on the case Dr. Afzal Rahman just presented, how you would tackle this case.
Okay, great. So, yeah, I'm trying to share my screen, but it looks like I have some issues. So, meanwhile, while I'm trying to do so, I just would say that this patient is presenting with several challenges, among those two challenges, I would point out maybe first the annulus size, and second, of course, this risk of coronary occlusion. Sorry to just interrupt briefly my talk, but it looks like that in order to share my screen, I must quit Zoom temporarily and re-enter. So do you allow me to do so, or I can even do just orally without slides?
You can try sharing your screen, that's fine.
Okay, so I'm coming back.
Can you share it on Zoom? Can you use the share option on Zoom and share your screen?
Yeah, but yeah, it's okay.
Yeah, we can see your screen now. That's good.
Okay, good. And
we can see both your screen and you, so we're good.
Okay, good. Sorry for this technical issue. So as I was saying, there are two issues in this patient. First, the small annulus, and I put the numerical values here. And the related risk is the risk of poor hemodynamic function of the valve, elevated gradient, severe mismatch. And on the other side, you have this small, tiny aortic root with low takeoff of the coronary artery, a small virtual distance between the implanted valve and the left main that represent a risk of coronary occlusion during the procedure, but also on the longer term, which is not something benign considering the age of this patient, some potential difficulty to reaccess the coronary arteries. So what would I do in my center if I would have to treat this patient? These are the platforms and the level sizes I have available in my center to treat this kind of annulus size patients. I wouldn't go for an Edwards 20 millimeter valve, considering the risk of poor hemodynamic outcome with elevated gradients. But it's true that this platform could be appealing because it would represent the easiest to manage regarding the coronary risk. But if we want to favor in this 75-year-old woman a good hemodynamic function, I would go for a self-expandable valve, and I have a choice between those two. I wouldn't take the Evolut FX23 because it's a supraannular platform. There is a 14 millimeter height skirt starting from the inflow. So in other words, it would make my life more difficult regarding the coronary parts of this case management. So I would go for the third one on the right of the slide, the Navitor 23, which offers similar hemodynamic profile to the Evolut, but which is intra-annular, so with some features making making the coronary issue management a little bit more easier. The second part is how to avoid the coronary risk obstruction. And in order to avoid that, you really need to deep dive in the mechanism and understand why it could be at risk of coronary occlusion. And here, the risk is related by this length of a leaflet as compared to the height of the left main, by this calcium nodule at the top of the leaflet. And if you simulate what will happen once the leaflet will be pushed by the frame, you directly understand that this nodule will be pushed in front of the leaf main and could create an occlusion. But if you see this simulation, you also understand that we have some uncertainty about that, meaning that we have at the top of the left main some remaining space that would allow for left main perfusion. The point is that we can't predict that with more accuracy with a CT scan. So in order to avoid that, of course, we have two theoretical options that you know, the chimney stenting, which is easy to plan and to do, but with inconvenience of having difficulty access to coronary arteries, or the basilica, which is the laceration of the leaflet. And here in that situation, we are quite in a favorable situation because the left main is just in the middle of the leaflet. So in my practice, if I would have to treat that patient, in order to rule out this potential uncertainty regarding the risk of coronary occlusion, I will first start my procedure with this maneuver that we were taught by Alain Cribier himself, which is doing an angio during a pre-dilatation in a projection totally perpendicular to your coronary arteries, predicted by CT scan, where you can really observe the movement of a leaflet and the calcification and have a better dynamic assessment of the risk. And then I will have two possible strategies. If on that maneuver of angio during balloon inflation, I would be convinced of a risk of coronary occlusion, I would have prepared everything and I would do basilica and then implant malvalve. Second option, if during balloon angioplasty and angio during balloon angioplasty, I would consider that we're still in a gray zone, intermediate risk, then I would protect my left main perfusion with a guiding catheter and a wire. I would implant my valve, and after, in order to determine the risk of true coronary occlusion by this calcium nodule, I would do an IVUS pullback, and you see here an example perfectly showing how this calcium nodule can be close to the outer wall and represent a risk of coronary occlusion. And if so, instead of implanting a long chimney stenting that would make the coronary reaccess difficult, I would come back with a second guiding catheter from the inside of the valve in a kind of ping-pong technique, rewire from the inside of the valve the left main, and then deploy my stent, but it would be a shorter stent, not making a chimney, but would be here only to push the calcium nodule away from the left main and maintain the coronary perfusion. So thank you very much, and this is basically what I would do for this patient.
Thank you so much. So would you preemptively engage the left main, put a wire down, and put a stent in case you need it? Is that what you do, or before you deploy the valve?
Yeah, in case I would still consider that there is intermediate risk of coronary occlusion based on the angio during balloon aortic predilatation, then I would do what I saw, this kind of ping-pong technique after stenting, and then I would not engage the stent down to the LAD from the beginning because I would consider that the risk is intermediate.
Okay, thank you. Any comments from Dr. Odhikari or Dr. Mominuzzaman? Anything, any suggestions you would do differently or any other thoughts?
I think this is a high-risk case for coronary occlusion, and as per the guideline, if the chance of coronary artery occlusion is too high, you have to send the patient for surgery. That's the preferred option. But even if you have to do it, then I think I'll go with a chimney stent. Just I'll put a guiding catheter with the stent, balloon and wire and stent in the LED, and I'll go with the balloon self-expandable valve in this case. Even what we can do is at the before we deploy totally, we can just give a check. If there is a coronary occlusion, then you can always withdraw it. And if coronary artery occludes, then we can pull a stent and just stent it the osteo left vein. Because this case is a high risk for coronary occlusion, that is no doubt. So first choice is surgery. Second one is with the balloon expandable, self-expandable, along with the coronary artery protection. That what I'll do it.
I think these are excellent discussions. Now, would like to know from Professor Afzalur Rahman what he actually did.
Thank you very much. I have exactly done what he demonstrated, but a little bit different, because every operator has a different attitude to thought. So my thought in this case was that this is high risk for cleft osteum. It could be on acute or it could be late, because there is a study that shows that if you put the valve in the discussion raised question, coronary maybe obstruction delayed. So that's why I've been keeping in mind that I will go for the Simri technique from inception. Let me see. This is the coronary angiogram. Kilo. চেক করে নাও নি তাহলে why is it hanged up? এখান থেকে আসো পরেরটা আসো তারপর চেক করে রাখলে কি এটা এরকম হয়? তুমি আমরা শিখাইতেছো, এখান থেকে শুরু করো, পরেরটা। হ্যাঁ, মুভি ওখান থেকে দাও, মুভ করে না কেন? ওকে, তুমি সাইডে থাকো। তুমি চেক করো নি তো তাহলে। তুমি পাশে থাকো। So I will not get enough time for that. For this, we can see that we are crossing the valve and then putting the wire. Next. What can I do now? ফাইলটা তোমরা নিশ্চয় চেক করছো তোমরা। পরের দিকে আসো। Keep it like that. So before before going to the crossing the valve, we put a wire and the stent into the LED. You can see that we are putting the wire here in the distal part of the LED. Then we are crossing. Then we cross the valve. Next. Then we cross the valve and we deploy the valve, and after deploying the valve, we find that it is nicely deployed with the gradient is 40, only the 10 to 15 millimeters. So then we decided to deploy the stent. Deploy the stent into the left main, so it should not be any problem. Though there is no acute occlusion, still we deploy the stent across the left main. You can see that this is the left main that was across we put a stent. So what we have done, before crossing the valve, we putting the stent into the LED by extra support wire, and then we deploy the valve, and then we pull back the stent and deploy the stent in the left main and protruding into the aorta. You can see that. No, the final result was very good, and we have followed the patient. The patient is now and this is the echo after 7 months. You can see that the gradient is only peak gradient is 21 and mean gradient is 30. That indicates it is a good result. And and what is the conclusion? Patient undergoing TAVR with high risk for coronary obstruction, presumpting stent implantation across the coronary artery improve the survival. Wiring only in the coronary artery have a considerable risk for delayed coronary obstruction. That is my thought. So meticulous planning and CT evaluation of the coronary route, aortic valve, and the anatomy of employs the need for the coronary artery protection of patient with increased risk of the left main compromise. Upfront coronary protection and the use of the stent implantation SIMNI technique is effective and prevent the acute and delayed coronary complications. SIMNI technique is very relatively safe, simple, and safe. Thank you.
Thank you, Professor Afzalur Rahman. Any question from the audience? Dr. Kamarkar, do you have any comments or questions?
No. Can you hear me? No.
Yes.
Yeah? No, just you, Nico, or are you in Dhaka? Can you hear me as well?
Thank you very much, sir, for his nice presentation. No. It was a challenging case. Actually, the coronary occlusion happened not by the valve, it is by the leaflets. So there is 3 factors for deciding whether the occlusion is happening or not. First is the coronary height, it is low, and the sinus of valsalva diameter. If the sinus of valsalva diameter is 30 or more, there you are in the safe zone because there is a room to accommodate the leaflet. But in this case, it was 23. So second, it is the risk case, and the leaflet length and diameter. I don't know the leaflet length and diameter, but there is 2 factors positive. So it is very high chance of coronary occlusion in these cases. But surprisingly, the ostium is not occluded during the surgery. But I don't know the experts can answer the question whether the preventive stenting in SIMNI technique is effective or not. I don't know. Because if the patient has if the patient has the acute emergency, acute ACS, how you will deploy the stent or how you will engage the catheter is a very difficult situation. Thank you, sir, for your nice presentation.
Thank you so much. I think that's a very important point. The sinus size, the sinus of Valsalva size is also very important in addition to the coronary heights. Absolutely, you're right. So that's why the CT scan and the planning is so very important when we plan any TAVI. So the next presentation will be by Dr. Dilip Kumar. Can we have Dr. Dilip Kumar connected online, please?
Yeah, I am connected, yeah.
Okay. Dr. Dilip Kumar, can you hear us? We can see you, but we cannot hear you. Can you unmute yourself, please?
I've unmuted, I think.
Okay, perfect. So I would now like to request Dr. Dilip Kumar to present his case on TAVR in severe calcific aortic stenosis with porcelain aorta.
Yeah, so let me share my screen. Okay. So I hope my slides are visible. My slides are visible?
Yes, yes, we can see them. Yes, thank you.
Yeah, so first of all, I'm going to present a case and then we will have a kind of opinion and then I will be showing what exactly I did. So these are my disclosures. So this is about a 76-year-old gentleman who is hypertensive, diabetic, and he was having a shortness of breath class 3 to 4 for last 1 month. And he was having signs of congestive heart failure. The bilateral pedal edema was there, and also patient was having bilateral chest crepitations. ECG showing some changes in lateral leads, ST depression, and echo showed severe calcific AS with gradient of peak of 126 and mean of 78. Ejection fraction was preserved, and an angiogram showed LED of 40% disease. So this patient, a 76-year-old male with a preserved ejection fraction, with no significant coronary artery disease or COPD, the patient was falling into intermediate category of risk for surgical intervention. So he went to a surgical, opinion and finally decided for a surgical ABR. So we got a distress call from the surgical OT. We were in cath lab, and as they were not being able to clamp the aorta because of severe calcification of the porcelain aorta. And the patient's chest was open and patient was about to be taken for cannulation, but because on the palpation, the aorta was so heavily calcified, it was porcelain, and surgeon, according to the surgeon, they are unable to put a clamp. And then they decided to refer to us what to do. So chest was closed and patient was shifted to CT room and with a TAVR protocol. And this was the CT analysis which we got. The area was 326.1 annular area, and the area derived annular dimension was 20.4. The LVOT was 20.7, so it was a tubular morphology. The right coronary height was 12.1, left was 15.7. Sinuses were roomy, 28.6, and 31 right, and none 28.6. So it was mean of 29 somewhere. It was not a very severely calcified valve. It was a moderate calcification was there, but aorta was severely calcified, and annulus did show some calcium, but it was not very chunky and very large amount. LVOT was free of calcium, and you can appreciate here what was the problem. Basically, the entire ascending aorta and arch was heavily calcified, and it was porcelain, so surgeon was not willing for that surgical aortic valve. It was a bicuspid type, zero aortic valve, and the right CFA was around 5.6, external iliac was around 5.4, and left side was, reasonably okay, 7.4 and 7, and it was less tortuous. So now my questions are, what all we can discuss here. Patient definitely requires a TAVR because there is no other option. So when we need to do a TAVR, when should we do it? When the patient is intubated, chest is being closed, CT analysis is being done, so should it be done by next day? Should the patient be extubated, or it should be done after 72 or 3-4 days after, or the patient should be discharged and being readmitted for a TAVR? That one decision we need to take. Should we take a central protection here, because the entire ascending aorta and arch is very, very calcified? Access, which access would be preferred? He has a very high bifurcation, and left looked fine. So what would be the choice of access here, and which valve? Since it was only 20.4, annulus, so which valve would be preferred here, and then finally which valve, size of the valve. So this on this, if we can have opinions and discussion, then I will go ahead with what exactly I did.
Thank you, Dr. Dilip Kumar. Now I'd like to invite Dr. Hidetaka Nishina to give his opinion on this case.
Right, thank you very much. Okay. So for indication, he's symptomatic 76-year-old male with comorbidity and very severe cardiac AS and posterior aorta protruding out cross clamp. So this is a class 1 indication for TAVR, there's no doubt. And for the axis, I only got the number, the diameter. However, from this view, the left femoral axis looks feasible. And any THV delivery system can go through this femoral arch approach. And for the arch, this is one big problem. There's a lot of calcium, as mentioned. And I think, since I don't see the original CT image, but from this 3D reconstructed image, I think there might be a lot of plaque. The shaggy aorta is very, very highly possible. So my concern is stroke during and after TAVR. So in that case, I may think about the cerebral embolic protection. Also, in the randomized trial, there were no difference in primary endpoint, the stroke within 72 hours. However, there was a reduced instance of disabling stroke when used cerebral embolic device compared to the control arm. So this is one. The another thing is, should we change the access? Are there any possibility of alternative access for this one? Because recently, I think transcarotid approach has become first choice for alternative, because when compared to transthoracic, there are reduction of death and newly onset atrial fibrillation, and when compared to the subclavian or actually approach, transcarotid TAVR is associated with less stroke and actually similar death rate and similar stroke rate when compared to the transfemoral. So in our center in Japan, now the first choice for alternative is almost carotid. And carotid is usually very less atherosclerotic when compared to the subclavian or femoral iliac artery. So let's go see the annulus. And this is, again, a very small annulus patient, area of 326 and perimeter of 65. Actually, this is the average annulus size for Japanese population, especially in the elderly lady. However, this is still small, so we have to think about the valve performance after TAVR. And when we look at the aortic complex, the patient has generous sinus. It's over 28, 29, and the STJ size is fine. Coronary height is high. So actually, any type of transcatheter heart valve can be chosen with regard to the risk of coronary obstruction. It's very low risk for coronary obstruction in this case. And for the small annulus, the SMART trial recently showed that when compared the SAPIEN balloon expandable valve and Evolute self-expandable valve, actually the self-expandable supraannular Evolute showed a similar clinical outcome, MACE rate at 1 year, but superior valve performance with regard to the biostatic valve dysfunction. So the performance is much better. So I would choose left transfemoral approach with, if available, cerebral embolic protection device, and optional maybe switch to transcarotid approach if the arch is shaggy and the carotid arteries are feasible for access. And Safari S or XS, it depends on the LV size, and Prebav with 18 millimeter balloon, or Prebav maybe skipped because of I don't see very severe calcification on CT snapshot. However, I would choose 26 millimeter self-expandable supraannular THB, elbow family to secure good valve performance. Thank you very much.
Thank you, Dr. Nishina. I definitely will agree with you on several points on those. I have a question for you, though. Did you mention the cerebral protection device you would use for this patient, or you would not?
If available, but I don't see the original CT image, so I'm not sure about the characteristics of the arch. However, if there's lots of plaque, I would.
So, with the protected TAVR tile not showing any benefit, and of course, it comes with an extra cost. Mm-hmm. So, how in your center, what are the cases that you would pick for protection device?
Well, especially for young patients with very severe atherosclerosis in the arch or ascending aorta, because we really want to avoid stroke in younger patients. So younger, high-risk patient. That's our indication so far. But we cannot use, even in Japan, we cannot use cerebral embolization protective device for all patients. Maybe at most 20-30%.
Yeah, the same is the United States as well. We are very selective, and of course, we do not use it routinely for the costs and also for the trial showing really no benefit. So we are selective, like you said. Anybody from the panel wants to make any comment before we go back to Dr. Dilip Kumar? Or anyone from the audience with any questions or comments? We still have, I think, Dr. Cousier and Dr. Dumontiel online. Any comments from our panel? If not, then we will go back to Dr. Dilip Kumar and learn from him how he actually treated this patient. Can we have Dr. Dilip Kumar back online again? We cannot see him. Can we get them back online? Okay. Dr. Dilip Kumar, can you hear us? We cannot hear you. You have to unmute yourself.
So I am unmuted here.
Oh, thank you so much. Now I would like to take a moment from me. I'm so sorry. I think Dr. Cousset and Dr. Dumontel can hear us now. Do you have any comments, any of you, about this case before we go back to Dr. Dilip Kumar? All right. If not, then Dr. Dilip Kumar, you want to tell us how you really did handle this case, please.
So am I audible now? Can you hear me now?
Yes, we can hear you, and we can see your screen as well.
Thank you so much. So it was a wonderful discussion, and the approach which was discussed was absolutely fine. And patient was taken to CT after chest was closed in the same day. And then we took the patient for TAVR after 72 hours. We allowed the patient to be extubated, and we saw that drains were less and the patient is doing well. Then we took the patient after 72 hours. And you see the right axis was not proper, and we took a left axis. Left axis, there was a problem that bifurcation was very high, and we had very limited space to puncture. You can see here. So it was a mix of combination of ultrasound guide puncture as well as fluoroscopy. So it was quite a high bifurcation. So left axis was, femoral axis was taken, and the procedure was not very difficult. So what exactly the site of the valve which we took? So we have two options. Self-expanding is always better in a small annulus, but this, the kind of a definition of small annulus varies from different trials, and it was rightly discussed that in Japan and India the average annular size is lesser what we see outside. So if we see annular size with body surface area, so something around 21 to 23, which we say, in different criteria as small annulus may not be small, in fact, for all of us. And when we look at how the different valves they perform, so we can see here my valve if we deploy a my valve of 21.5, the hemodynamics of my valve 21.5 matches with 23 mm self-expanding valve. So when we look at the the dimensions here, if the area is 26 and the area derives 20.4, when we take my valve, 21.5 my valve would be 11.3% oversizing, and 20 my valve would be 3.7% undersizing. So what we did was we took a 21.5 and we took the 1 cc less. So we were kind of 5 to 6% oversizing, and then we went with a 21.5 valve. And there was no difficulty in taking the valve. We did not pre-dilate because the valve was not very severely calcified. In fact, the aorta was calcified. We used the flex navigation system which is there in my valve, and we went across the aortic valve, and it was approximately 80-20 deployment of a 21.5 valve with 1 cc less. And finally, when we saw this, we took a final 1 cc extra, and we went into for nominal again, and that was the final result. So we accepted this little layer because the diastolic pressure was around 70s, and then again post dilatation with same same balloon at same nominal pressure, we got this final result. So while coming out, you see we had taken one ProGlide and it got snapped off, and in this situation we had to deploy a urgent covered stent here. And this is how the patient was rescued from peripheral side. You can see here, with such a small period of time, the patient had a kind of hematoma, building here, so that you can see indentation in the bladder. The contrast image can be we all can appreciate. And the patient developed a prolonged PR, and he went into transient heart block next day. And then we deployed a conduction system pacing here. You can see here it was a CSP. And this was the ECG which we got, a pseudo RVV pattern and a narrow QRS. So this is what we are doing, and what I wanted to show here, the kind of decision making and all. And once the patient developed a complete heart block or AV blocks or prolonged PR with symptomatic conduction disorders, we go for a conduction system pacing in most of our TAVR patients, as this is an acquired heart block which we are giving to patient. And if we are treating this, patient should not be left out with the LVB again through a device, and because LBB can predispose the patient for a cardiac dysfunction in future. So summarizing this case, this was a bailout tower from surgical operating room, and we do see these kind of cases, and in future I think such cases will be even more. Access was tricky. Right was not a very large vessel, good vessel. Left was a very high bifurcation. We had a very less place to puncture it, and it was a small annulus. We took my valve because of based on results like landmark trial showing that my valve gives a better hemodynamics than Edwards, and it is as good as the next size of self-expanding valve. And ProGlide break can happen, and in this situation, the best option is to put a cover stent. And conduction system pacing is the way to go in all acquired heart blocks like this patient. So thank you so much, and we can have some more discussion on this. Thank you so much.
Thank you, Dr. Dilip Kumar. Dr. Dumontel, can you hear us? Are you still online with us? Well, Dr. Nishina, you mentioned alternate access for this patient. If you would not be able to get access from the femoral site, would your preferred access be carotid, or do you use any other? What's your preference for non-femoral?
Recently, my number one access would be the carotid, especially for the left carotid is my favorite alternative. Because actually the carotid access was approved last year in Japan, so I still have only 12 cases of transcarotid. So far, no stroke, no bleeding event. So I think it's quite a good access, I think. Much better than transaxial.
That's exactly our experience is. We switched to carotid now from transaxial. We work closely with the vascular surgeons because, of course, they have to do the cut down. But our success rate has been very good so far as well. I see Dr. Kuset is back online. Any comments on this last case about the access, Dr. Cusette? Any other question from the audience? Otherwise, I have one more question for you, Dr. Nishina. The question is, when you have like a baseline conduction disease, like a right bundle branch block, you know the patient will have high chances of having a pacemaker. In those cases, what's your like precaution you take when you know the patient may get a permanent pacemaker? Or may even, sometimes we see you put a wire down and the patient goes asystole, flatline. That happens to you, right?
Yeah, that happens.
So what do you do in those? What's your way of taking precaution?
Well, I think most physicians prefer balloon expandable over self-expandable valve for such kind of patient, but still, if it's reasonable, I don't hesitate to use self-expandable valve even with a patient with right bundle branch block, because we can actually control the depth of the implantation. And actually, we can redo it with self-expandable valve. I think that is a beauty of self-expandable technology. And actually, we try to implant the valve as high as possible for both type of self-expandable or balloon expandable, whatever. Yeah, just positioning is very important.
And is your practice normally like when you are putting the temporary pacemaker to use the femoral or the IJ?
Actually, my practice femoral.
Femoral.
Yeah, it's much faster.
So this is some people I've seen that doing is that when they have high suspicion the patient may have permanent pacemaker, they have to at least watch it. They put an IJ so the patient get up and walk at least, you know.
Yeah. That's the same, I think.
Yes.
Sometimes, yeah.
Okay. All right. So any other questions or comments from the audience? If not, we will request Dr. Robin Chakraborty, who's online with us, to end our session with his closing remarks, please. Dr. Chakraborty, can you hear us? Do we have Dr. Chakraborty online with us?
Dr. Robin is in a procedure. I think he was busy with a patient.
Well, in that case, I think one final word I would like to say again for the young physicians. When we show you these cases, when we show you these cases, we always show the challenging, difficult cases. But please keep in mind, TAVR is not as bad. You do not have these complications in your cath labs every day. So don't get disheartened or discouraged by this. So I know TAVR is picking up, you know, with the leadership and the pioneers like Dr. Kamakar, Professor Afzal Rahman, Dr. Mumin-uz-Zaman, Dr. Qasim Nasrullah. They have started this in Bangladesh, and we hope TAVR will pick up in Bangladesh as well. So please be positive about the thoughts. In that case, we have Dr. Thomas Quisette. Are you online with us? Can you hear us?
Yeah.
Oh, perfect.
Can you hear me?
Yes, we can hear very well.
Because I tried to make some comment during the session, but I think there was some technical issue that I was not able to fix, but my mic was on, so but that's fine. I think that was beautiful cases, and as you said, I think for our young colleagues to try to share experience and difficulties is probably the best way to improve our practice and the patient outcome.
So any other comments? We really would like you to make the final ending remarks for our session today.
Of course. Of course, no, I think the selection of cases were really ideal because the first case and the risk of coronary obstruction during TAVI is increasing, and we know that it will be even higher during the redo TAVI procedure that we will see arriving at the second wave, probably. And I really like, what Nicola described is the concept of the ping-pong technique. It means that when you have high risk of coronary obstruction and you put a self-expanding valve, if you have occlusion, then you have to do the KIMNE. But if you don't have immediate occlusion, but just the risk of occlusion, I think it's good to re-engage through the valve, and instead of having a KIMNE between the aortic wall and the valve, just to have a stent through the struts of the valve, because we know for the long-term follow-up it will be much safer. And I think the second case was the ideal case also to discuss the value of cerebral embolic protection, because we know that the risk of stroke is low during TAVI, but when it occurs, it's really a nightmare for the patient and the family. And thanks to the British study, we will have very soon in ACC the largest randomized trial, which will be presented in the coming weeks. So probably we'll know more about the value of this device during the TAVI procedure. And just as final word, I would like to thank you, all the community from BIT, from Bangladesh, India, and beyond. And it was great pleasure to just be connected today. Hopefully we will be able to join you physically in the coming years. Every year I said to Afzalur that I will come the next year, but at some point I will have really to say yes for the next year because I keep amazing memories from my stay in Dhaka and Calcutta with all the BIT community. So on behalf of the PCR board and your PCR, I wish you a very successful meeting. Always pleasure to be with you, and hopefully we will see most of you during the upcoming EuroPCR in the next May, and it will be the next good occasion to try to share our practice skills and to improve our practice. So again, thanks a lot, and looking forward the next collaboration.
Okay, thank you. Thank you, my friend Thomas. Thank you very much. Hope I will see you in person next time. I will not forget. Okay, thank you.
Thank you so much, everyone. With that, we conclude our session. Thank you so much.
So we are now moving to the next session, which is the challenging cases. My name is Dr. Raza. I'm from United Kingdom, and I have the honor to moderate this session. And my co-moderator is Dr. Asaduzzaman. He is with us, and Dr. Afzalur Rahman and Dr. Maske from Nepal will be in the panel. So we will be presenting 3 cases, which are the challenging cases, and then we'll have a discussion about these cases. So I have the honor to invite the first presenter, Mr. Ashok, Dr. Ashok Datta. He will present the first case, and then we will discuss. Dr. Ashok Datta, please.
হবে না আমার ল্যাপটপে নিতে হবে হ্যাঁ দেখেন তো না পেন ড্রাইভে চলুক তাহলে দেখেন চলে কিনা জাস্ট আই ক্যান ট্রাই আদারওয়াইজ আই উইল টেক মাই
So, thank you. Respected moderators, chairpersons, and my dear teachers and learned audience. How should I treat the challenging case? That is not actually challenging, but a complex case. So my patient was 55 years old male, hypertensive, diabetic, creatinine was raised with eGFR 40 ml per minute. PCI was done previously in 2016 with DES in the proximal LAD. The previous record and CD was not available. LV ejection fraction was normal. Patient presented with crescendo angina. There was some STT change in the infralateral leads. We did the angiogram. This is the angiogram. Left main seems to be normal, but there might be some lesion. Stent in the proximal LAD, but osteoproximal LAD was uncovered. LCX osteum is severely diseased, as well as in the first OM, that is very much close to the osteum of the LCX. RCA was non-dominant and very smallish vessel. So basically, this is the LCX osteal lesion followed by OM lesion. Left main is looking good. So the next question is, what should be the treatment option? Is it provisional from the left main to circumflex followed by DCB in the LAD or bail out DES if necessary in the LAD? Or we should go for upfront double stenting strategy, either DK crash, culotte, or TAP.
Thank you, Dr. Datta. If you please stay with us. So, yes. And we have the comments from the panelists as well as from the audience to make it more interactive. See how the other colleagues do this case. So first of all, I will request Dr. Shams Munawar to have these comments. How would he treat this case? You want to come over?
It's okay, thank you. It's indeed a very challenging case, no doubt. I mean, osteal LCX always scares me. Anyway, the left main is not that bad actually. So why should I go to stent left main is a big issue actually. Anyway, I'll definitely do an IVAS to assess left main here. That's the first thing. Probably at the end of the day, you have to do something because you can't just leave a stent at that short length of the L6 osteum. So I'll go for the left main to L6 stenting, keeping a wire in LAD, but I don't think I'll do anything to LAD at the moment unless really essential. And about that OM, really after doing that stenting to left main to L6, then I'll make a decision. Probably I think just to do a DCB in that osteum. And it all depends on actually on the that I was finding. Did you do an IVS? Yes,
I did the IVS.
Okay.
Yeah.
Okay.
That is very.
So to summarize, what will be your strategy? Drug eluting balloon, single stent?
Yeah, my strategy will be single stent here. Single stent to left main to L6, provided LAD is okay. And really keep it that way. And maybe then another drug balloon in that osteum of the OM.
Thank you so much. Now we move on to the next panelist, Dr. Vikramarachi. So let's see what Dr. Vikramarachi do if this is his case. Dr. Vikramarachi, your
comments. Thanks, yeah. I would agree with the previous comments. So assessing left main to LAD, see whether it's significant, either through IVUS or even physiological assessment like FFR and the LAD. But it looks like the circ is going to be significant. So I would be keen to just pre-dilate and see it, keeping the option of DCB open for everything, from left main to circ to OM. But always have a stent strategy in the back of my mind, if needed, to stent from left main to circ and then provisional to OM.
Dr. Maske, would you have any different strategy, or what are your comments on this? And how would you treat this?
Yeah, same comment. Go from left main to circumflex, do IVUS, assess, see LAD, and then proceed. So the main strategy is go from left main to circ. So cover that one. I'll not go for DCB because I'm not very convinced about the long vessel size and no data.
To make it more interactive from the audience, anything to be added, or anyone who will treat differently, raise your hand and have the mic. Anyone from the audience? Okay, no option. All right, so let's see what Dr. Dutta did about this case. How did he treat? Dr. Dutta, could you please come and
yes, so thank you, panel of expert board, giving the expert opinion. So I agree, and it is not coming. Yes. I did it more or less in the same way, but here the IVUS or other imaging technique sometimes give a crucial report. Initial planning was to provisionally stenting from left main to circumflex, as the other panel mentioned, and plan to DCB in the osteoproximal LAD, and as well as DCB or POBA to the OM. So first I wired with the worker source, see on blue and run through. There is no such difficulty in wiring, but LCX was a bit difficult, but anyway without much difficulty wired the LCX, LAD as well as OM on. Then I did the IVUS from the LAD to left main. That shows left main stent was OL opposed and there is no significant lesion. LAD proximal about 5 to 6 millimeter is uncovered by the stent. And other significant findings was the left main was moderate lesion at mid and distal segment. That was not visible in the angiographically. If we go back to the angiogram in the allocranial view, sorry. So this view, actually this shows a different way. Left main, definitively there is disease. The same thing is seen in the IVUS recording. So our strategy is become easier. I tried for IVUS from the LCX, but IVUS catheter cannot be negotiated because there was a tight lesion. Then I predilate the vessels, LCX OM with 2.75 balloon. Then I did the IVUS from the LCX to left main. That shows an interesting report that ostium of the LCX is fibrotic, and angiographically that was looking well expanded, but there was no dissection and the crack was not present there. So that is an important issue in any ostial, either ostial LCX, ostial LAD, left main. So if there is no crack, and if we put the stent, subsequent proper apposition, expansion will be very much difficult. And for proper expansion, sometimes we inflated at high pressure with NC balloon, and that's sometimes produce the strut fracture.
So with the help of cutting balloon, predilate the LCX ostium perfectly, and this is the result after perfect predilatation of the LCX ostium. So then I put the stent from left vein to LCX, 3.5 into 28 millimeter, then pull back the stent balloon and high pressure inflation. Then I did the port with 4O balloon. Predilatation, then crossing the OM and the LAD. Predilatation of the dilatation of the start in the LAD and opening up the start to the OM, and then kissing balloon inflation between circumflex and the OM. So this is the result after stenting from the left vein to LCX, opening up the start in the LCX OM ostium and the LAD ostium. So should we finish here, or we should go for IVAS and further intervention? So with the thought that we have done the LAD ostial predilatation with 3O balloon, so there is some injury and there was some plaque burden in the proximal LAD by IVAS. Initially, I shown it. So I put a DCB 3.5 into 20. After 60-second inflation, I just pull back the DC, same balloon, and another balloon in the LCX ostium, NC balloon 3.50, and then did the kissing bell between the LCX and LAD. So DCB in the LAD and NC balloon in the LCX. After kissing, this is the result. At that moment, patient complaining of chest pain, but that is very much surprising. The OM was almost totally occluded and dissected. So it was wired, then predilated, and another 2.5 into 9 millimeter DCB in the OM with kissing balloon in the LCX and OM. And this is the final. Afterwards, further we did the port in the left vein. And this is the final result. Left vein MSA was 17, LCX that was 12.4, and LAD proximal that was 11. So it is on your follow-up. Patient is doing well. So high-dose rosuvastatin with double antiplatelet. So the key message, IVAS or OCT play a crucial role, especially in complex PCI cases. Isolated LCX is, especially when it is dominant, is difficult issue. DCB or hybrid DCB and DES is very much useful in complex, especially in bifurcation lesion. Sometimes that DCB make the complex procedure much simpler. With this, I like to thank all my colleagues. I like to thank BIT for inviting me in this session.
Thank you very much, Professor Dr. Ashok Datto, for your excellent case and great case. Actually, it's a very complex case. Have any question? Yes?
Yeah,
yes,
I have
yes,
a
sure,
question.
sure. You can
Great
ask.
case, Dr. Datta. I don't have too much experience with DCB in the US because they're very expensive, so we don't get to use it as much. When you did the 60-second inflation, did you notice like any chest pain or anything? Because this involved the left main, right? And how did the patient tolerate a 60-second inflation?
Exactly, that is very important. I covered, on the DCB in the LAD, I covered the ostium of the LAD. there was definitively pertusion in the left vein, but patient tolerated well that time. Because by this time, throughout the procedure, at least about 40 minutes I have passed before putting the DCB, there may be some ischemia preconditioning. So I feel many patients, initial stage of the procedure, patient complain of chest pain, but subsequently, later on, that complaint usually goes away. So even in the left vein bifurcation, through and through, sometimes, and other procedure, other technique that I use, not only me, other colleague, I think, short inflation for 30 seconds. That is an
that's in the U.S. The limited number of times that I've used it. I've done 2 30-second inflations. Yes. Because they say the greatest dispense of the drug is in the first 15 seconds. So if you do 30 seconds, that should be enough. But 60 seconds, I mean, the patient did great. Your result was phenomenal. I think I'd be more scared being up for 60 seconds.
Thank you.
Thank you. If there is no question, then I ask for our next speaker. Our next speaker is Dr. Anindam Pandey. He is from India. And his title is How You Come Across a Left Main Where Nothing is Left. Arindo, can you hear us? Arindam? Arindam Pandey, we cannot see you or hear from you. No, we could not understand whether he is connected or not.
If there is any difficulty in connecting, are we connecting with Dr. Pandey or? So we can move to the third presenter, and while we are connecting with Dr. Pandey, can I now request I have a pleasure to invite Dr. Arifur Rahman from United States to present his case, and then we will have a discussion. Thank you, Dr. Arif.
Hello, can you hear me? Okay, assalamu alaikum everybody and good afternoon. Thank you very much, Professor Afzal Rahman and the rest of the BIT for putting together this wonderful conference. It's been a great experience listening to all your talks and hearing all the wonderful cases that you do all over the Southeast Asian region. So I'm going to share a case that I did. So I'm from Pittsburgh. I'm the chief medical officer, but I'm also the director of the cath lab at the University of Pittsburgh Medical Center. And before I start, I do want to share that the way our hospital system is set up is that my hospital is the main academic tertiary care center. And we have a lot of small hospitals nearby that are community hospitals, and patients go there first, and then they end up getting transferred here if there's any complicated case or if they need higher level of care. So just keep that in mind when I discuss my case. So for the interest of time, we have an 84-year-old gentleman, history of hypertension, diabetes, PVD, with bilateral below-the-knee amputation. He presented to an outside community hospital complaining of fever, chills, shortness of breath, and some chest pain. It's been going on for about a week. So, when he came in, we looked at his history and everything, nothing significant. He takes amlodipine, benazepril, insulin. He was a heavy smoker, but quit 30 to 40 years ago. And other than that, nothing much remarkable in terms of his past medical history. His vital signs and his physical exam was more or less normal, nothing out of the ordinary. His blood pressure was a little bit soft. His SBP was around 103, and his diastolic blood pressure was around 50 on presentation. Labs on admission, the labs that were notable for, whereas hemoglobin was 10.4, his creatinine was 1.8, which is above his baseline. His baseline from about 6 months ago was about 1.1. And his high sensitivity troponin was initially 1169, and the subsequent one was 3644. LFTs were essentially normal, and his lactate was a little bit high at 3.4. When we looked at his EKG, as you can see, he's a little bit tachycardic. He's in a little bit of an accelerated junctional rhythm with some wide QRS. He has some diffuse ST depression, but no clear ST elevation MI, so there was no need for a primary PCI. So based on this EKG and his elevated troponin, the team outside decided to treat him as a type 1 non-STEMI. They put him on aspirin, they put him on Plavix, they put him on a high-dose statin, and they wanted to get a TTE, an echocardiogram, to assess his LV function and compare to his prior one to see if he has any wall motion abnormalities. Okay. So as you can see, his septum's a little bit down, but overall EF, they reported it as around 35 to 40%. Here's the short axis view. See, the anterior septal is not coming in as well. Here's the 4-chamber view. We ended up using Definity for better opacification of the ventricles. Here's his 3-chamber view. So at this point of time, given his low EF, or EF of about 35, 40%, and some new wall motion abnormalities, his type 1 non-STEMI, the decision was made to undergo coronary angiogram, and this was all done in the outlying community hospital. So as you can see, he has distal left main extending into the ostial LAD. His ostial circ is very tight. Proximal circ is 100% occluded with some left-to-left collaterals. He also has like a mid-LAD lesion. Here's another view. You can see the mid-LAD lesion here. You can see the collaterals fill up in the left circumflex. Here's the spider view. And here's the right. It's a small non-dominant with diffuse disease. So other information is that he was also diagnosed with the right lower lobe pneumonia, and as we saw from his creatinine, he has acute kidney injury. So he was started on antibiotics, and they decided that since they cannot do bypass there or high-risk PCI, they transferred him to our hospital. So when they called me and I was on call, I said, okay, fine, bring the patient over, put him in the CCU, and we'll evaluate him tomorrow morning. It's around 10 p.m. I got this call. So he comes into our hospital, and as soon as he reaches our hospital, he starts having like chest pain, nauseated, he starts throwing up, and he was having a lot of sinus arrhythmia. He was having sinus pauses, PVCs. So then, the cardiology fellow called me and said, what do we do with this patient? He just doesn't look very good. So I think before we talk about the plan, I'm going to ask you guys about how you want to proceed.
Thank you, Arif. It's a wonderful case. So it's an NSTEMI type 1 and having infection, pneumonia. So it is really a kind of chip case with some impaired left ventricular function. So I think it is really something which needs to be handled with expertise. So we start from this time on the other end of the panel. Dr. Maske,
thank you.
Then you followed by Vikram Rachi and then Mr. Munawar.
Yeah, so it's
before we do this, can I ask Arif, what was the pneumonia? Was the X-ray pictures like?
It wasn't too very bad. It was like a loculator, like a small right lower lobe pneumonia.
So basically, it's a condition where there's a lot of comorbidities, including history of pneumonia, renal impairment, and thing is, this is a heart team approach. So if the surgeons are willing, because I see a lot of calcifications in the LAD, ostial left main, so it's not a simple procedure. If the surgeons are comfortable, then discuss with the heart team. Surgery should be first choice. If not, then PCI should be definitely the options. But there are a lot of comorbidities, calcifications, vessels are not easy. That's what we should make a heart team approach.
Thank you. Dr. Vikramarachi, how would you treat this case if you are the treating cardiologist?
I mean, it sounded like when he was transferred to your center, he was pretty unwell. I'm not sure whether we'll have enough time to discuss with surgeons in that situation. So maybe just crack on with, temporary wire if needed, and assisting left main, try and open the circ, probably the culprit. I think I would push on.
Is there any chance of asking for any support or anything, or we should go ahead and fix the lesion? So any idea about?
I mean, the LV isn't. I mean, was he on inotropes? I didn't quite gather.
Yeah, he was a little bit of inotropes.
He was
so
on
basically, he's heading towards shock, and has got, you see, critical lesions involving left and 3 vessel disease. So in that case, how many? Could you raise hands, those who will go for any sport like balloon pump or any left ventricular assist device? Those who go for it, can you raise hands, please? Who would use any left ventricular sport device in this patient? 1, 2. So 2 in the hall. And out of you, how many would like to do the sport?
We don't have impeller. We have balloon pump. I'll have a balloon pump ready, but
so
I don't.
Here you don't have impeller or balloon pump. What do you say, Doctor?
Yeah, I mean, if you have, definitely you assess the patient in cath lab. If it's the low blood pressure, and that should be ready, and if required, you should put that one.
Dr. Shams Munawar?
Same, we don't have the impeller, but definitely if you have impeller with that LV dysfunction, with the low perfusion, I think it would definitely be helpful, no doubt.
Okay, thank you so much. Any comments or any questions from the comments, just to make it more interactive? You want to ask any question from Dr. Arif Rahman, or should we? Any questions? Go to the mic and ask the question, please. Please introduce yourself and go ahead for the questions.
I'm Dr. Mohsin. Actually, the patient has a very non-dominant RCA, but you are going to intervene on a left main with a CTO of LCX, and it's a calcified vessel. We anticipate a very complex PCI in this case. Had it been a dominant RCA, we fix it first, then the things become relatively easy. But here, I think hemodynamic support can play an important role in bailing out the patient in this situation, actually.
Thank you. So I hand over to Dr. Arif Rahman to see, to answer the question and to complete his case. How did he treat? Dr. Arif, thank you.
So, in the US, we have the luxury of having mechanical support. And as Dr. Mohsin mentioned, that we're dealing with one system, which is the left system, and it's very tight, it's heavily calcified. So whenever I get cases like this, I do try to use some kind of support because it gives me plenty of time. I can take my time, do atherectomy, do bifurcation stenting, balloon it, take my time with the inflations, and I don't, worry much about it. So I decided to proceed. So questions about, bypass. So this was around 10 p.m. at night, and we do have, 24/7 cardiac surgeons. So I always do like a quick mini heart team. So I did call the surgeon in. He came in, he looked at it, and he said, with his bilateral below-the-knee amputations, he's not a good substrate for, bypass, especially with his creatinine up, and it looked very heavily calcified. He has pneumonia. He says, Arif, it's all yours. You handle this. So then I decided to go ahead and, I started to proceed with an impeller. So I put a 14 French sheath in the right femoral artery, and I put a 3/5 impeller in there, and I put a 7 French guide. No difficulty in crossing the valve using the impeller. So my plan when I went in was that after I do the stenting, if everything goes very well and smoothly, I will try to wean off the impeller at the end of the case and take it out. So here's a nice picture with the guide. Okay. So I ended up double wiring. I thought I was going to attack the mid LAD first, and I had difficulty advancing the stent, so I ended up putting a third wire down the diagonal, and I ballooned it and was able to stent that. So this is what the mid part looks like before I was going to attack the left main. So we had a lot of difficulty in getting the balloon in and trying to inflate it, so I put a guide liner catheter in, and I ended up using atherectomy. So any thoughts from anybody about what kind of atherectomy you'd use? Because I couldn't inflate it with the balloons. I even tried a non-compliant balloon. You managed to do an IVUS? I did an IVUS later on, but I couldn't even get the IVUS in because it was so heavily calcified. So any thought about what kind of atherectomy? So we just ended up using the CSI orbital atherectomy. So I ended up, buzzing it down the left circumflex. I took it down to the LAD. Then I ended up ballooning it. And I had to take the guide liner in pretty deep. So this is what it looks like after a lot of balloons. I did one more run of atherectomy. So how would people stent this? What would be your technique to stent this? All right, so I decided to do like a culotte because I felt that the left main or the LAD and the circ were pretty equal size. So I ended up putting a 3.5 by, I think it was a 38 promus from the left main into the left circumflex. Then I rewired through the stent strut. Then I put another stent in there. This was also a 3.5 by, I think it was like 30 or 28. Then I did a kissing balloon and we IVUSed it afterwards. Sorry, I don't have the IVUS pictures. I couldn't download it. And this is what it looked like at the end. But we did IVUS this. I know there's a little bit of haziness there, but there was no dissection, nothing there. It actually looked pretty well opposed. It looked pretty decent. And then we were able to wean off the impella at the end of the case. Any questions?
Thank you, Dr. Rahman. It's a great case. Can you share him?
Sorry, didn't get you. What are the atherectomy devices you use?
CSI.
Oh, CSI.
CSI, orbital atherectomy.
Okay.
Why you prefer the orbital atherectomy in these cases?
So when I was on call in the middle of the night, the staff was very comfortable in setting that up very quickly. That patient was not doing very well, so we said, let's just use that one. But I've used both the rotablator and the CSI.
Okay, thank you.
The CSI, in my opinion, has a little bit less risk for perforation.
Okay.
And when it set the calcification, we figured we'd be able to, do like orbital atherectomy.
Can I?
What about using the IVL here? Would you have been able to use IVL here?
You failed to cross the lesion with the simple, I think, it's a small size of balloon you hit. Yeah?
So we had trouble getting a balloon down
Yeah,
there.
yeah.
We tried to use a guide liner, and then we ended up using the atherectomy. And once we used the atherectomy, we were able to advance the balloon easier.
I am asking you just like a layman type of questions. In this case, do you think of the extra cardiac cause, that is pulmonary embolism, do you think in these cases?
Excuse me, sorry?
First presentations was a dyspnea, and it was a cardiogenic shock in the filial patients. Could you think of second diagnosis of pulmonary embolism in these cases? Can you think?
Yeah, sure, we could have thought about pulmonary embolism, but if you look at his vital signs, his oxygen saturation was about 98% on room air. So, his lactate was elevated, so it showed signs more of cardiogenic shock.
Can I ask you one question, please? Why didn't you consider decay crash here when the evidence of decay crash is favor for the distal left main one? And can you, one more, can you consider DCB for the circulation after preparing the bed so that you avoid the double stent and all this complexity?
Sure, it's a great question. So this was done about a year ago, and that time we did not have DCB in our hospital. In fact, even now, we very rarely use it because of the expense. So that's that. Yeah, you could use DK crush. I was talking with a cardiology fellow, and I always try to encourage them and empower them. What do you want to do? And they thought about doing culotte because of the sizes of the vessels. So we just decided to proceed with a culotte. But you could use DK crush, yes.
I'd like to make one final comment, Arif. So this was a great case, and those of who work in the United States, we're very fortunate to have the mechanical circulatory support device like Impella. So now we have a shock protocol because these are the patients who are going to crash very soon.
Right.
So he's giving all the signs. So we have started a shock protocol, like we call it shock alert.
Right.
And then the interventional team comes in, and even if they're not intervening, they will at least put an Impella in to save this patient. So
that's correct. And as Dr. Khan said, we do have a shock team. And like how you activate the cath lab, we also activate the shock team. And we all, some people get on the phone, people come in, and we end up doing a quick evaluation of the patient of what's the best treatment approach. And that also helps us because that's kind of like a mini heart team as well, where if the surgeon does not want to take this person for surgery, they'll document it and it makes it easier for us. Thank you very much.
Thank you so much, Dr. Arif. A wonderful presentation, and we enjoyed in the interest of time, we go to the next presentation, which is on the bifurcation PCI, and it's about 10 to 12 minutes presentation that I'm going to give. So bifurcation PCI from global perspective. So my name is Dr. Raza. I'm consultant cardiologist from UK. I have no conflict of interest. And as you know that these are the techniques which are widely used all over the world. And it is now widely accepted that single stent strategy is the default strategy. But in most of the cases, like 70%, but small percentage where intention to treat is 2 stents, these are the various techniques everyone knows. The crush, the current data suggests that the crush, which is either DK, mini, or nano crush, and the culotte, they are the most widely employed techniques for 2 stents bifurcation treatment. And followed by T and TAP, and sometimes V-stenting, and this SKS, or the simultaneous kissing stent, is no more in fashion because there are negative data about simultaneous kissing stents, so it's not being done anymore. Now, it is very important to remember and mention the landmark studies on bifurcation PCI, like Cactus by Dr. Colombo, Nordis, the Norwegian trial, the bifurcation, British bifurcation, or the BBC-1 study, and the COBIS-2 and COBIS-3 registry from Korea. They are very, although it is older, they are studies, but they are landmark studies because they are important, because they trigger the advent of new devices and designs and further randomized controlled trial from China, Professor Chen series, and also the EBC main trials. Now, it is beyond the scope of this 10 minutes presentation to go through to all these studies, but I will just pass on and stop my slide here. Now, this is the meta-analysis of 5 studies, and none of these studies have shown that single stent or 2 stents are better than 1 stent, and there is no significant difference of mass events in these studies. However, the results of these studies are important because these trigger the invent of new devices and techniques which have long-term global effect on the treatment of bifurcation lesions. For example, introduction of intravascular ultrasound and 2nd and 3rd generation stents. And these are not only the devices, but also the techniques. For example, if we choose carefully the stent diameter with distal reference rather than proximal reference, then it is, and then do a proximal port, then we make sure that there is no, gap left behind the stent. Similarly, if we choose to elect TAP technique, mini crush, or T techniques, it is very important to position the side branch stent so that we do not create a geographical miss. Similarly, rewiring from proximal or distal, depending on the DK crush that needs, it's very important to do wiring from the proximal stents if we do the DK crush. But more important is the final part, and which actually makes sure that there is no space left between the stent and the vessel wall, and this can be confirmed through intravascular ultrasound if it is available. And last but not the least, it is the final kissing balloon dilatation and final port. whatever the technique you choose, it is extremely important that we do final balloon kissing and the final part, just to make sure that the geometry of the bifurcation is restored and there are less chances of restenosis. Actually, the data has shown that if, this is based on the data from 2014 until 2015, that you can see that the target vessel failure, the incidence is much, much less as we have the more new devices and more techniques available. So there is actually a difference in the recent years. And now coming to the more advanced studies, DK Crush 3 was the first study that compared the DK Crush stenting versus Culotte. More than 400 patients were randomized to receive either DK Crush or Culotte stenting, and this is the result after 12 months angiographic follow-up. There is much less incidence of MACE events in DK Crush group as compared to Culotte group, which is shown in yellow. Another landmark study is the DK Crush 5, which compared between the DK Crush stenting and provisional stenting in distal left main stem. More than 480 patients were randomized to receive either DK Crush or the provisional stenting, and there is much less incidence of target lesion failure with DK Crush. That is the reason it had an impact on the guidelines of European guidelines, which recommended DK Crush may be preferred over provisional stenting and is placed in class 2B, whereas stent implantation in the main vessel with provisional balloon or stent remains class 1 indication. Now coming to the European bifurcation study, more than 460 patients randomized to have either stepwise provisional approach or systematic dual stenting, and this is 12 months data followed by 3 years data. There is no difference between the stepwise provisional and systemic dual stenting in terms of death, MI, or revascularization. There is no big difference. This is a very important study actually that changed the practice. This is the Definition 2 trial. More than 600 patients were randomized to have either provisional stents or the upfront 2 stents. And the selection of the cases were based on definition. Definition means all the complex cases like, calcification, bendy lesions, and also the angle of the bifurcation. So these are the factors which would select, and these are very selective cases. So that means this 2-stent strategy is better than provisional in this special group. This is the 12 months follow-up. The incidence of target lesion revascularization is much less in 2 stents as compared to the provisional stents. Now, this meta-analysis is very important based on the randomized controlled trial on 21 trials. And they recommend that provisional stenting has been recommended as the default technique, which we all know. A clinical benefit of 2 stent techniques was observed over provisional stenting in bifurcation with side branch length more than 10 millimeters. And for upfront 2 stent technique, emerging data supports DK Crush ranking #1 in probability of being the best treatment for all outcomes, followed by Culotte and provisional stenting. Whereas the T-TAP and classic crush were least likely to be the best treatment, but I not fully agree with this because it is basically the registries from Korea. They do a lot of mini crush, but there is no randomized controlled trial. Now, another important thing is that it also depends on the skill and experience of the operators and the geography of the, you see, over worldwide, as you can see from the slide, there's patients with left main who need 2 stents. The Japanese like to do more of Culotte followed by T-stenting, whereas the Korean operators, they tend to do more of crush, classic or mini crush, and followed by T-tap. So it's not only one single stent, it is your experience, the way you are trained, the way you are experienced, so that you choose the best technique for 2 stents. And my 2 last slides. Now, there is a document which is the Asian Pacific Consensus document published in Euro-Intervention 2020, because we work in this region. Standard of practice varies across the Asian Pacific region due to difference in culture, socioeconomic state, and healthcare setup. And many patients would opt for PCI rather than bypass graft surgery, regardless of the prognostic implication. And the availability of PCI infrastructure, including physicians and devices, is limited or financially unaffordable. So the practice may differ from the rest of the world in our regions. Therefore, we can't strictly follow all the guidelines, the European and the American guidelines. And although the document is fairly in agreement with and is complementary to European Bifurcation Club, but many patients and perhaps many of the interventionists may avoid time-consuming or expensive two-stent strategy. Now, to conclude my presentation, it is now agreed that more than 70% of all bifurcations, the stepwise provisional approach is preferable. And the data supports that the fact that we should use one stent if we can, and two stents if we must. So the definition criteria is to identify a complex bifurcation lesions, have been confirmed by meta-analysis, hence can be used for intention to treat two stents. And DK crush has got the strongest, evidence in its favor. And systemic two-stent, particularly DK crush, is associated with low rate of target lesion failure for complex bifurcation, left main true bifurcations. So we can choose any two stents technique we are most comfortable with, like DK crush, or it may be culotte, maybe mini, nano crush, or T-tap, but we must do final part, and final kissing balloon as a rule, and because this has impact on the long-term results. So head-to-head comparison of DK crush with culotte, there is one study which shows that crush is better, but I think we need more studies to compare DK crush with mini crush, nano crush, and possibly need for further randomized controlled trial. About bioscaffold stents, although they have failed, but I think that is a very promising one option in future, because that is the only way that we can get rid of the metal from the bifurcation and giving a good results. And I thank you for your kind attention.
Thank you very much. Thank you, Dr. Afsar, for your excellent presentations. Now the floor is open for question and answer. Have any questions from the audience? Please ask your questions. If there is no questions from the floor, may I ask our panel of experts or discussions, Dr. Arun Maske, have you any questions or a few comments regarding the presentation?
So all cases were good, and the message is, whatever the study says, two-stent strategy, do whatever you are used to. These DK cross and all are done by very experts. If you are starting the case, you learn one technique, master it, finish that case, and then after you go to other techniques.
Yes, I totally agree with this. So, okay, if there are, yes, please go ahead.
No, there aren't many studies, but I was surprised you didn't talk much about drug-coated balloons in a bifurcation talk. I think there is a EBC study being planned as we speak, if I'm not mistaken.
Yes, you can tell us the results. That will be good.
No, it's being planned. So I mean, if you look at the registries, of course, very little RCT data, but in practice, especially in the Asian region and part of Europe, I come from Simon Center in Norwich, so we've used quite a lot of DCBs in bifurcations, including two-vessel DCBs in bifurcation.
I think this is a very good, actually, comment, because we need to have more data for use of DCB in bifurcation. We have seen one or two cases today, and I think it is very promising. But the only difficulty is in complex lesions, where there is a bandy calcification. There are more dissections, so the choice of DCB is limited in some of the cases. So that I agree, but it's a very good, actually, new thing that will come up. Any other comments?
Any comments from Shams Manor?
Thank you. No, nothing much comment really. I try my best to stay to single stent strategy. Unless absolute treatment, if two stent required, I take time to find which technique is suitable. I most of the time prefer DK crush actually. It gives a very good result, like long-term result. But I must say, if the angulation is favorable, color technique also gives a very good result, no doubt about that. And about that DCB, I actually do the DCB the side branch if it's not calcified. That gives a good result actually. Thank you.
Right. So before my colleague wind up the session, can I ask what are the operators in Bangladesh? What is the favorite, technique in when they use two stents? Can you raise hand to those who do DK crush? How many they do DK crush? 1, 2, 3, 4. And how many do culotte? 4 or 5. So it's almost equal. So I think this is what data suggests, that culotte is more popular in UK and US, and as compared to Asian countries where probably the crush is more prevalent. And what about any mini crush here does? So mini crush is quite. So I think it's a very good actually. We need to have more controlled studies comparing crush between mini crush and crush. Mini crush is actually good. So I hand over the mic to my co-moderator just to wind up the session, and then.
Actually, there is another announcement. Dr. Arindam Pandey, possibly he wants to join with us. If authority permits, then I could permit the Dr. Arindam Pandey. Dr. Arindam? Yeah? Arindam, can you hear us?
Yes, sir. I can hear you. Yeah.
Okay.
Yes.
Share your slide and start your talk.
Oh, thank you very much.
Good afternoon.
Good afternoon. I'm very feeling so sad that this time I could not be there in Dhaka. So I was discussing probably in last 10 years.
We cannot hear you clearly. Arindam, we cannot hear you clearly.
Can you hear me clearly now?
No. A bit louder, I think. You need a bit louder.
Hello? Hello?
Yes.
Hello?
Now it's clear.
Okay, thank you.
Can you share your screen?
Sure.
Yeah.
Hope my screen is visible.
Yes. Slide is visible.
Thank you.
You can continue.
Yeah.
Yeah, sure.
So let us start the case. This was an interesting case. The 73-year-old male, hypertensive diabetic, presented to me with features of unstable angina, ECG revealed left bundle branch block, complete. Though the ejection fraction was maintained, 60%, no wall motion abnormality, and the TROP T was positive. Now, after medical rehabilitation, she was having very significant chest pain, so we decided to go for angiography. Let me show the angiogram directly, because this is very interesting angiogram. So when we did the angiogram, it was like horrible. Whole of the left main, there was a trickling of flow to the LAD. Circumflex was totally occluded. And very importantly, you can see the calcification. There was tram track calcification starting right from the left main, which is extending both to the LAD as well as LCX. The distal LAD, we can see the vessels getting bifurcated like a septal magnum and a very large diagonal. But there was a landing zone before the bifurcation, but the sarc was totally occluded. So this was the left side, and I'm showing you the caudal view. This is the caudal view. So suddenly you'll have a feel that after some time, after some opacification of the left main, it is totally occluded and only few specks of calcification getting divided into circumflex and LAD territory. And this was the right-sided angiogram, which shows the proximal and mid portion of the RCA. There is hardly any lesion, but PDA, there are some stenosis. And very interestingly, you can see the circumflex, left circumflex, which is very nicely filled by collateral circulation. So very optimal filling of the circumflex. That is why there is no probably no wall motion abnormality in the echocardiogram, though the circumflex was non-dominant, but it is very nicely filled from the right side. So at this stage, we are having a patient of triple vessel disease, Lippmann equivalent Lippmann, with a very high syntax score. We calculated the syntax score, it was 32. So we offered him bypass surgery. He was a 73-year-old gentleman, diabetic, hypertensive. So we felt that bypass surgery is a very good option. We referred the patient to surgeon. They accepted the patient, but somehow the patient party refused the surgical intervention. They were very much averse. At the same time, they had some issues with finance as well. But the problem is patient was still admitted and having significant on and off chest pain, both at rest and even with minimal off exertion. So at this point, I think I should stop my presentation. So that someone else can continue regarding how the other operator will plan it.
Yes, Dr. Pandey, thank you so much for this case. Now everyone knows, now we see how the colleagues who are sitting in the panel, they would go ahead and treat this case. What I can see is that there is a good collateral flow from right coronary artery, which actually gives you a very good spot and good time to do the work. So we start with Dr. Munawar. How would you treat this case if you are the treating cardiologist? Thank you.
This is indeed a nightmare case. The question, I couldn't get a very good view of that LED very well. Anyway, the L6 is completely obtruded and is filling quite well from right coronary artery, meaning it's more or less chronic. The main problem patient is encountering at the moment, most likely from the left main and LED and coping the LED. Left main, if I could, I didn't get a very good view, but I think the left main appears very calcified or a thrombus, something sitting there. So, anyway, if it's possible to get a view by putting an IVUS inside, see the left main how it is. If it's very heavily calcified, then probably patient needs some debulking technique. And opening up the LED and left main, I think, will be the main objective here. I really can't make any comment beyond that, actually.
Sorry, Dr. Pandey, we do apologize. We have a live case actually directly coming. Is it possible that once the live case is finished, then we come back and continue this discussion, if that is okay with you? Or you can quickly finish the case. Or if you finish the case, you tell us how you did treat the case quickly, and then we wind up and then take the live case. Thank you. Yes, please go ahead. How did you treat this case?
Okay, so I'll show it. I'll be trying to as brief as possible because I can see a live case is on the board. So I agree with the panelist because the circ is very nicely filled from the right coronary artery. So definitely it is a situation when the left main and LED is creating the problem. So this is the part 2. I already start with my last slide. Syntax score 32, financial problem. That was very important for my patient. So we decided this is the, we can see the calcification. The problem in this case was the calcification and totally occluded left main. So how common is the calcification, prevalence of calcium in current day-to-day practice? We know 70% of the PCI, the calcification is either mild or there is no calcification. But around 25% of patients, they have moderate calcification, around 6% have severe calcification. How do you diagnose? How do you actually look ahead from the angiogram? If the radiopaque density noted only during the cardiac cycle and typically involves one side of the vascular wall, that means there is at least moderate calcification. But if the radiopaque density noted without cardiac motion and prior contrast injection, and if there is something known as trunk tract calcification, that means involving both the side of the arterial wall, then this is definitely a severe calcification case. And we need to have something beyond the normal angioplastic technique. We need to have some debulking tools. Either it can be a rotablation, orbital atherectomy, it can be IVL, it can be laser, whatever. So my case is an example which typically shows a very severe calcification and which is starting right from left main.
Dr. Mohammad's presentation is here.
So final plan of management, we gave the option to the patient that probably will go ahead with rotatripsy. That means combining rotational atherectomy with IVL, followed by IVAS guided cutting balloon angioplasty. But the total cost, the finance was not actually accepted by the patient. Second option which we offered is the orbital atherectomy followed by IVAS guided cutting balloon. Again, in this part of the world, orbital atherectomy is still costlier than conventional rotational atherectomy, so the cost was unacceptable for the patient. So third option, which actually offered, was rotational atherectomy followed by IVAS guided cutting balloon angioplasty. Somehow they accepted it from financial point of view. Now, I agree with the panelists that the LCX, which is a non-dominant vessel and very nicely supplied by the right coronary artery, we are not going to, touch the LCX in the current, setting. So probably that will help to alleviate the symptom of the patient. So we started the case. We planned to do the left main to LAD, and the wearing was little difficult. And you can see with some trial, we could wear the left main to LAD. And then we thought it might be a thrombus because some of the panelists, they mentioned it may be a thrombus. So we took a new 2 millimeter semi-compliant balloon, but to our utter surprise, the balloon did not cross. So probably it was not all about thrombus. There was very significant calcified stenosis. You can see on the right-hand panel, the 2 millimeter balloon is not crossing. So we had to have a baseline IVAS. To get that, we had to create a passage. So we took a 1.5 millimeter Rudy balloon to have a basic passage so that we can take our IVAS down. Then we took the same 2 millimeter balloon and opened the artery to some extent. Then this was the picture. We can see the artery more clearly now. The distality also, the wear was in the diagonal, so we repositioned the wear. And after this, we took the IVAS. I'd like to, take some time to, see the IVAS image. This is the mid-distal LAD on the right-hand panel. You can see it's a big vessel, but very, very calcified, almost 360-degree calcification. And the left-hand side, you can see the proximal LAD. Now you can see there was a calcific nodule. So that is almost a nightmare. Whenever you come across a calcified nodule or calcific nodule, that is not something good to have for intervention cardiologists. The proximal left main was good, and you can see the calcified nodule. So for calcium nodule, none of the conventional technique for the calcium management are actually good. Orbital probably have some edge, but somehow due to financial constraint, we could not take orbital. So we decided to take conventional atherectomy, but we took a bar size, which is more than normal. We started the case because we had option of only one bar. So we started the case with 1.75 rota bar. And you can see with some effort, we initially exchanged the rota wire through a microcatheter. And with some effort, with gradual, meticulous ablation, then we could actually reach the distality. And after that, we can see the vessel now looks better. The calcium is now far better. Then we took 3.5 millimeter non-compliant balloon, cutting balloon in the form of Wolverine. This is a balloon which is on sale from Boston Scientific, very good balloon. And this cutting balloon, after this cutting balloon, you can see we went ahead, we went up to 18 atmosphere, which is probably not suggested, but in our center, we go with very high pressure cutting balloon predilatation, and this was the result. After that, we can see the proximal LAD also showing a vessel of 4 millimeter, and you can see the cuts made in the calcium, clear-cut cuts, and this is the calcium nodule, calcific nodule in the proximal LAD. Still it is there, but you can clearly see it is now moving around. So right and left movement, and on the side, the cuts are very nicely, done. So after that, we took a drug-eluting stent. It was a Megatron stent, 2x20 Megatron from Boston Scientific, and you can see how we deployed it. And after
sorry for interruptions. Actually, we are running short of time. Live case study, please show us very shortly and complete your case, please.
So fine. After the final IVAS, this is the final result. So you can see the result is very acceptable, and 1 month follow-up, patient is completely angina-free, restarted regular activity, and in fact, he is riding bicycle. With that, I should stop here.
No.
Thank you very much.
Thank you very much. Thank you again. Yeah. May I request Dr. Khalid Mohsin to conduct the next session. The next session is the live case, and before that, I conclude the challenging case sessions. I must thank the speakers and discussants for their live discussions. And now I want to hand over my mic to Dr. Khalid Mohsin to conduct the next session. Thank you all.
Can you hear me?
Thank you, Dr. Asaduzaman. Coming up is a live case from Ibrahim Cardiac Center, and the principal, the operators are Professor Saidur Rahman and Mashudia Chaudhuri. They shared the same nickname
I will.
Mishu, and nice to see them together working. Professor, Dr. Saidur, can somebody?
Yeah, can you hear me?
Yes, we can hear you loud and
clear. Okay, already I think 15 minutes late. 4:30 it should be. It is supposed to be.
Please let
by
us
this
know
time
about
I have
your
started
case.
only. I have started here. I am just I'm welcoming you from Ibrahim Cardiac, and the case which I'm going to perform today, or I am in the middle. Dr. Sabah is going to present the case history or the.
Amal, please have your seat as a panelist.
Dr. Sabah,
here.
please.
Yes, sir. Assalamualaikum.
Dr. Syed Ali Hassan, are you here? Dr. Raza is here.
Okay, I'm going to, Dr. Sabah is going to present the case.
Welcome to the live case transmission program from Cath Lab of Ibrahim Cardiac Hospital and Research Institute. Today's operator is Professor Dr. Mohammad Saidur Rahman Khan sir. So our case is a 75 years old lady who has a history of diabetes mellitus, hypertension, and a known case of CKD. She is also a cervical carcinoma survivor. She presented with effort angina, CCS class 3. Her ECG was within normal limit. Echocardiogram revealed no regional wall motion abnormality. Ejection fraction was 65%. Coronary calcium score was 1864. Estimated GFR was 32 ml per minute. She led a sedentary lifestyle naturally and was hemodynamically stable. She also is a high bleeding risk case. So this is the coronary angiogram showing heavy calcification of the left system. Distal LMS has significant bifurcation lesion with biosteal involvement, Medina class 111. L6 is tortuous with severe diffuse disease. Epicranial view showing mid-LAD has significant lesion and diagonal branches are narrow calibered with diffuse disease. Dominant RCA is heavily calcified with severe diffuse disease. Now we are moving on to the main attraction of today's program, the live case transmission.
Yeah, Dr. Mohsin and the panelist and the Dr. Mohsin. So already, can you hear me?
Yes, we can do.
Okay, already we have started here. Obviously, Ibrahim Cardiac is an extreme radial center. So we have started with the transradial approach, right transradial. And I have taken the 6 French guide catheter, JL's 3.5. And this is the first picture we have taken by the guide catheter. And you see that the calcification is even angiographical is very severe in the distal left main and also in the LAD and also in the LCX also. And this is the epicranial view also you have seen here in the mid LAD or early mid LAD has got a severe disease with calcification also. And this is what we have done. Go for the next. We have wired the LAD first. We have already done something there. because it was late and patient was lying down for a long time. So we have done the IVAS, and I'm going to show you.
Sadur,
Yeah.
before starting your case, if we can hear from you, what are the considering the total scenario, right side LCX and LED, and left main ostia bifurcated lesion, and also LED mid lesion, what are the possible strategy and what is your strategy?
Oh, that's I'm also asking you also, for you all the panelists.
Because you
what
start
is the
considering
my
mind
possible
that
thing is that surgeon has refused to
what you are doing.
Go for it, and what we have done, just we wanted to go for a provisional philosophy for the distal left main and also the medial AD, and also you have a diffuse disease in the principal vein branch, which is also calcified. So that one we have to deal with. And also you have to see how much the LCX osteum is going to behave and whether we need a upfront to stand strategy or not. Still, I'm not pretty sure of that one. And that's why I've just I have done for the wiring, and I have done the ballooning, and I have done the IVAS. So you can see the IVAS, and then also you can discuss that what would be the next strategy.
Saidur, what is the syntax score of this patient?
Syntax score is more than 32.
And was she offered a option of CABG?
She is 75 years old and literally 40 kg weight, and the surgeon has fled the scene, and also patient party is also a sister, elder sister of a physician, and desperately he didn't want to go for it even.
Actually, you are intervening on the left main, but the right side seems quite severely diseased. So could you have done the right side first for a better support for the left main intervention?
It's not, because it's a CCS case, and also there is no collaterals or supplying this area or from that area. It's not like this. So it's better to go for the left main.
Can we take any decision from the foreign faculties in the audience?
Yes, I would like to ask the panelist, Dr. Raza, what would be your strategy in this case?
Yes, I think since this is a teaching and learning course, so my reservation will be the same. If we have more support from the right coronary artery, which is quite strangulated, and I wonder if there is, you are the best person because this is your patient, but I think to give more support from the right side, probably one option is to fix the right first. And but anyway, whatever you chose is the best. This is your patient in the best interest of the patient. Thank you.
Professor Azizul Haq, would you like to comment a little bit on it?
I think I quite agree with the Dr. Raza that actually he should think about the right coronary first, then he could go through for left main and the LED. Okay.
And do you think a staged procedure can be a better option for this lady of 75 years, cancer survivor?
I think stage procedure is much better here.
That's good. So in this case, I will go for the RC as a stage procedure. So we have started with the left main because that's, it's a different animal, and I want to finish it. I want to do that one. I want to be happy with that one. That's the possibility here. So what we have done now, so we can show it now. The IVAS. No, the IVAS.
In the meantime, we can discuss. There is two school of thought. One is that the difficult lesion, which may be catastrophe or may need to send the patient surgery like this, if in the thought in mind, then we touch this lesion main. In this, the left main bifurcation lesion is this type. So we do first this, then do the simple lesion.
Yeah.
And another strategy is get the support from the simple lesion, then we touch the culprit severe lesion or difficult or may play ancestral lesion. So we get some support from the right side. These two school of thought is in
okay. Can you show the IVAS picture now?
Yeah. There is calcified.
You can see the IVAS here. Yeah. So in the mid LAD lesion is calcified, but it's a 90-degree calcification is there, is eccentric, not that much, but severe calcification in the osteoproximal LAD, about 360-degree, and then also in the distal left main. Can you see that one? And the left main is around 4. So you have seen the IVUS here? Dr. Amol, have you seen the IVUS? Right?
Sir, yeah, I'm
Okay.
seeing
We'll go forward because the patient
there
is
is a heavily calcified
very
in
much
a
old.
10
Yeah.
to 12, 10 to 11
Yeah.
o'clock position.
Yeah. Now I have gone for the
But
LCX
stop, it
also.
stop, not run.
No, I have gone for the LCX. Next picture. Because the principal
not
vein is
running.
also big. It's also almost a codominant system. So I have gone for the LCX distal, the principal vein branch, which is really huge and supplying a large territory. So I have ballooned it, pre-dilated with an NC balloon, and then I have gone for forward, and then I did an DCB here, not to put a stent.
I think what you strategy adopted, you need a lot of stent.
Yeah, that's why less
before
metal is
touching the
good.
left main. Because
Yeah,
there
less
is
metal
also
is
another
good.
lesion in the LAD mid.
Yeah. So that's why I have fixed the principal vein branch with a DCB after proper vessel bed preparation. So you see that reasonable flow is there, a little bit dissection, which is really helpful for late luminal gain ultimately. And this is the picture after this. And so I have gone for the, go forward. I have already pre-dilated the early medial lesion. And then, because the calcification is less there, so I have gone for the stent here with a 2.5 because in IVUS shows the distal reference diameter is around 2.5. So 2.530 onyx stent and inflated it. And after that, this is the picture. And you see that we have done an IVUS here. Go for the IVUS again to see. Can you show the IVUS now? In the stand, because there are some malpositions there, so we need a post-dilatation here. Now, what about the distal left main and the osteoproximal LAD? Go.
Still running, but it's not clear to see. Calcification is definitely there is in this.
Yeah, it's
position,
too much.
There is
because,
a discrete calcification at 270 degrees.
Yeah, because you see that even the calcium score is around 2000.
Dr. Saidur, are you happy with the result of a drug balloon in a calcified OM?
Not optimal, because you know that you have to be like that in case of DCB, angiographic pictures will never be like a stent. Go.
Angiographic picture we did not see still. Then we can do command.
In calcified arteries, I think DEB is not the ideal choice, I think.
Now I am doing the osteoproximal and the distal left main with an IVL. Because it's a 360 degree. There's too much calcification here. Some sort of bradycardia and significant ECG changes here. Still, it's not cracked, the calcium. So I'm doing the IVL here with the 3.5 IVL I've taken. Now it is inflating.
Dr. Saidur.
Yeah.
How will take decision for the fellows or our younger?
When you have a 360-degree
whether you use
calcifications
whether
and
in this
eccentric.
case, what are the criteria to use IVL or ROTA?
Oh, this is for you know that safer for to prevent distal embolizations and other things, and also you say it's not a long segment calcification, so IVL is enough if financially patient can provide it.
Because there is a definitely financial issue to use IVL.
Yeah, that's what I'm telling. Of course, ROTA and IVL are not. Yeah, it's a complementary thing to each other. It's complementary to each other, so you can go either way, this way or that way. But for this lesion with around 20 millimeter calcification, you can make it safe by the IVL. So now the enough crack is there. I want to see it that how much crack is there by an IVS again after IVL. I think it is now dilated well.
Dr. Saidur, renowned imaging specialist Dr. Akasuka has joined our panel. We will have some input from him regarding the intravascular imaging after you
I'm showing
done
that
with your job.
That's good. That's what I wanted also. Okay, run it. Show the IVAS, and please, Dr. Akasaka, please inform us, enlighten us with the IVAS imaging. It's not an HD, so I'm sorry for that.
Yeah, I'm not sure where it is, but then here you can see the severe calcification at 9 o'clock, right? And the branch comes, it's with a guide wire there, right? And almost circular calcium.
Yeah.
Right? Yeah, and then, yes.
I think after IVL it is cracked or not, Akasaka?
Yes, this is in the fibrous mainly, right?
Yeah, but after IVL, whether it is cracked now, I think it is cracked, right? The calcium.
I'm sorry, I could not see. Could you repeat again, right? This is
Whether,
after IVL.
Yeah. Okay. They're running again.
I cannot see clearly. Here, the 6 o'clock, yes, and also the 12
Maybe the distal LMS,
yes.
you know, the distal LMS has got 360
yeah,
degree.
here, yes, we can identify, yes.
I think it is cracked
yes,
is there, right?
Yeah, yes, you're right.
So I can put a stand now, comfortably?
Yeah.
Yeah?
Yeah, oh yeah, this also, some crack, yes.
Yeah, 3.5. 30.
So,
No, 30.
It is very important, as you said, the make a crack.
Yeah.
To obtain the well expansion, right?
Yeah. So I'm taking a 3.530 stand, Onyx.
Yes, 3.5. Yes.
Whatever it is.
Dr. Sadhur, mediality you have deployed which stand?
I'm not hearing.
Mediality.
Yeah, Dr.
Onyx.
Yeah, Onyx. Yeah. I'm taking the Onyx because it's expandable, you know.
Yeah.
And also trackable. Give me the stand, please. So I'm taking a 3.530. The left main looks like 4, right, Dr. Akasaka?
Yes, you're right. Yes.
I hope that LCX ostium is not going to create any too much problem for this old, low-weight lady to make the case much more complicated.
Because LCX ostium, I think it is almost healthy, having minor plaque maybe. So
no, calcification is there, severe calcification is there.
You are adopting the provisional stenting, yes?
Yeah, provisional philosophy is, usually I want it for every left main.
But because you have IVAS, you can show us the ostium of the LCX. Can you show us? Dr. Sadhu, you are expert in the IVAS. So can I ask one question to you?
Yeah.
Due to financial constraint, can we use the scoring or cutting balloon instead of IVL in this case?
That will be, the scoring and cutting can help, but not all the time it is cracking. Yeah, it is very, very much hard. You see, why the IVAS? Please show me the angiographic view, because I am just struggling with just parking the stand. Okay, let's see.
Yeah.
Yeah, it was really, really troublesome. I have to deep intubate the. Yeah, up it.
If the thickness
I
of
was
the
struggling
calcium
literally.
is
down.
nearly less than 500 micron, we can make a crack by using a cutting balloon or non-compliant balloon. But by IVAS, we cannot measure the thickness correctly, right? At that time, I think OCT might be very useful. But this only one part circular calcium, but the other part are free of calcium, not on a free cover.
What is happening there?
The calcium, not
balloon.
360 degrees. Therefore, we may have a chance to make some dissection using a cutting balloon or non-compliant balloon, right?
Sorry, I have one question. Can I have one question, please? This is with regards to this degree of calcium and the use of IVL. Any one of the panelists experienced that we can get away simply with non-compliant balloon and just do the procedure, complete the procedure? Because
I am agree with you. At least me is agree.
Because the problem is the cost, in our kind of setup.
Yeah, Dr. Arun.
I have another question to
Dr. Arun Maske.
Can we?
Yeah.
Can we left?
Is it Arun Maske?
The few millimeter of the ostium of the left main to reduce the stent size?
Sorry?
Because can we take the little short stent to avoid the ostium of the left main?
Yeah, it might be better.
Oh, because no, it's because it was not designed. I didn't go until up to the ostium.
Because EBCTAL said that.
Because you know that the pot, pot, you see the 8 millimeter I need for pot. Okay, up. Down.
All right.
Still calcium is resisting. Yeah, it's going slow, easy. Hope for the CX is up. Okay, down.
Dr. Sadhu, you are using the 15 4. 15
4.8 NC.
4.8 NC.
Okay. 8 because pot, you have to do. I have to.
But it looks like longer. 12 or
no. Because it's hopefully the CX is not creating any problem now. Now I want to go for the IVAS. Again, Dr. Akasaka, please help us also to see whether I have to go for. I have inflated 4.8 balloon up to 20 atmosphere.
But still distal left main and proximal LED is still under expansion.
A little bit because you have to.
Saidu, can you listen to me? Where you are handling the case, it is not right. because you did not predilate the lesion appropriately. And
I have predilated it. I didn't show you.
Not really. Did you take the 3.5 balloon or even 4 mm balloon?
Yeah, I have predilated all these things.
But is there?
I have done it before.
No.
Before deciding for IVL.
Okay, thank you. But your student
I have done it. I didn't show all the things because already 15 minutes are late.
Can you give him time to settle down? And in the meantime, can you give another talk? Because we have one more talk.
Okay, Saidur, we will come back to you. You continue your finishing touches to the procedure.
Okay.
And we have another quite related talk by Dr. Mamas on PCI in cancer patient. You have shown a procedure on a cancer survivor. I would like to invite Dr. Mamas to talk on PCI in cancer patient. When do you need to know?
Before that,
what do you need to know?
Dr. Akasaka can tell us about the IVUS.
No. You finish it. We will come back to you. We will come back to you. We will come back to you.
We'll be
We'll come back to you. We know you are the very expert operator. You handle the thing. No problem. But we will come back to you.
Okay.
We'll see the final pictures after Dr. Mamas has finished his lecture.
Okay.
The slides on, please.
No, niche 2.75 under ase.
Of Dr. Mama's slides. The IT professional, can you please help to put the slides on the screen? Oh yeah, it's here. Yeah.
Okay, thank you. So my name's Mamas Mamas. Over the next 10 minutes or so, I'm going to talk about what we need to know about PCI in patients with cancer. Maybe I can start the talk by asking you, put your hand up if you do PCI on patients with cancer. So put your hands up. So there's a lot of people that haven't put their hand up. So that means either they don't do any PCI, or it means they don't recognize the patients have cancer. Because I can guarantee you, every single person in this room has done a PCI in a patient with cancer. Now you may say, well, why is this important? Why is it relevant? This is rare. It's not rare. If you look at data that my group has published, 40 million patients, cardiovascular disease has declined. It's declined by 10%. Cardiovascular disease in patients with cancer has increased by 25%. So these patients are coming to our cath lab more commonly. 1 out of every 10 PCIs that you do will be a cancer survivor or a patient with cancer. This is highly relevant. And the greatest risk is in patients that have just been diagnosed with cancer. You can see that within the first year, the rate of cardiovascular disease is very high. This is other data that we've published. Over half the patients that die with cancer from cardiovascular disease are coronary deaths. And the reason that coronary disease is so common in patients with cancer is because they share the same risk factors: smoking, diabetes, obesity. Many of the cancer drugs that we give cause atherosclerosis. Radiotherapy causes atherosclerosis. And also many of the drugs that we use to treat cancer can cause plaque rupture, vasospasm, thrombosis, and so forth. So it's very common in patients with cancer. So the first question I get asked is, should I revascularize patients with cancer? Well, we don't have data, but what we do have are randomized controlled trials in non-cancer patients. And we know from data from Courage that outcomes are not improved in stable coronary disease. We also know that if you follow the patients up for up to 12 years, the outcomes are no different in courage. We also know from the ischemia trial, again, overall, no difference in outcomes, although there may be a benefit in terms of myocardial revascularization. So, in stable coronary syndrome, in patients with cancer, you should treat them with PCI if they have symptoms that is not susceptible to medical treatment. Otherwise, medical treatment first. PCI does not make cancer patients live longer. It does not make patients without cancer live longer either. Acute coronary syndrome with cancer, should I treat invasively? The answer is yes. Any patient that comes in with an acute coronary syndrome that has cancer, as long as their life expectancy is more than 6 months, you should treat them invasively. Why do I say that? This is from our publication that we published a few years ago from US data showing that consistently patients that have PCI in their cancer consistently have better outcomes. You can see this is treated medically, this is with PCI. Consistently for every cancer, if you do PCI, they have better outcomes. And actually, the benefit of PCI in patients with cancer is as good as in patients without cancer. So you have a primary, you have an NSTEMI, as long as their life expectancy is over 6 months, treat them invasively. This is data from the US. 1 in 10 patients that has a heart attack has a history of either current or prior cancer. If you treat them medically, their outcomes are much worse. So you can see that patients with cancer have worse outcomes, but if you treat them medically, outcomes are much, much worse. Patients with cancer, if you look at why they die, if they have a STEMI, this is data from the UK, the vast majority of patients with cancer that have a STEMI die from cardiovascular disease. So it's not a cancer death, it's cardiovascular disease, hence why it's important to do PCI in these patients. We know that patients with cancer have an increased risk of major bleeding complications and also an increased risk of stent thrombosis. But the main problems is bleeding complications. Cancer patients are high bleeding risk. This is data that my group has published, 6 million PCIs in patients with cancer over a 10-year period. And what we show is that the outcome depends on the cancer type. So first and foremost, the majority of cancers don't have worse outcomes with PCI. So if the patient has prostate cancer, breast cancer, or colon cancer, the outcomes are very similar to the non-cancer patients. It's only when they have lung cancer that the outcome is worse. Okay? So the prognosis following PCI of cancer patients is good. Secondly, it's only when they have metastases does the prognosis get worse. So if they have metastases, the prognosis gets worse. If there's no metastases, it's very similar to non-cancer patients. The main problem is bleeding. Patients with colon cancer and lung cancer particularly have increased risk of bleeding complications. And so if you have to do a PCI in someone with GI cancer or lung cancer, you need to think about bleeding complications and treat them as high bleeding risk cases. And so when you're doing PCI, you need to think about the balance between bleeding and ischemic risk in these cancer patients. As I've said, cancer patients are high bleeding risk because they've got cancer, but because also they may have liver metastases, they may have anemia, they may have low platelet counts, they may have coagulopathies, or they may have planned surgery for their cancer, so they're high bleeding risk. So the ESC guidelines say that for patients presenting with ACS, you should do invasive treatment in these patients if their life expectancy is greater than 6 months. And the ESC guidelines also say that in high bleeding risk patients, you should give 1 month dual antiplatelet therapy. So remember, in patients with PCI and cancer that have colon cancer or lung cancer, these are high bleeding risk patients. If you do a PCI, 1 month DAPT in these cases. again, you've got to think about the cancer types. A woman with breast cancer is not going to have high bleeding risk. You can treat her as you would with another patient. A patient with active colon cancer is going to be very high bleeding risk. You need to make short DAPT. A man with prostate cancer, again, is not high bleeding risk. A woman with lung cancer will be high bleeding risk. So you've got to think about the cancer type as well. And this is the last slide. We've just published this paper in the European Heart Journal. It was chosen as the top 10 paper in the European Heart Journal of last year. And what we did was update the precise DAPT score. So now you can use the precise DAPT score for cancer patients to calculate the bleeding versus ischemic risk. So for the majority of cancer patients, their high bleeding risk use 1 month of DAPT. For some cancer patients, like breast cancer patients or prostate cancer or skin cancer, their bleeding risk is very low, so you should give 12 months. Colon, lung, hematological malignancies, high bleeding risk, short DAPT. So I think in summary, every one of you will treat a patient with cancer. Patients with cancer have as much benefit from PCI as patients without cancer. These patients are at increased risk of bleeding and ischemic complications. The important thing to do is think about what is the cancer. If the cancer's colon, hematological malignancy, or lung cancer, these are high bleeding risk patients, you should give them short DAPT. Everybody else, give long DAPT to. If you want to personalize your approach, use the precise DAPT cancer score that we've just published in the European Heart Journal. You can find the app on the website and you can precisely calculate the bleeding risk of your patient and personalize. So the take-home message is, if you see a cancer patient, don't say they've got cancer and treat them medically, do PCI. These patients have as much to benefit as patients without cancer. And with that, I'll stop and hand back to the chair. Thank you.
Thank you, Dr. Mamas, for your very thought-provoking lecture. Actually, physician inertia is quite common in treating patients with cancer, particularly in our part of the world. So it will help overcome to this physician inertia to some extent. Before I go to my panelists, I'd like to pose one question to you. Do you face any additional technical problem in performing a PCI in a cancer patient who has got extensive radiation to the chest? Like in the patient of lymphoma, breast cancer, lung cancer, do you have any experience about that?
Yes, so patients with radiotherapy tend to have very fibrotic, calcific osteal disease. In those patients, I use very low threshold for a cutting balloon. Every patient with cancer should have imaging, and the reason being, if you have a catastrophic bleed or their platelet count comes as very low, you may have to discontinue the DAPT much shorter than 30 days. And so if you do intravascular imaging, you're less worried about stent thrombosis. I've done left main cases in cancer patients where I've had to stop dual antiplatelet therapy after a week with a 2-stent approach. I wasn't worried, and the reason I wasn't worried because I did intravascular imaging.
Dr. Saidur has probably finished his case, and we will come back to him. Before that, Professor Azizul Haq.
Yeah, I'm going to show you the final pictures and final IVAs.
Yeah, please, just a minute. We hold on for a minute, sir. Just we want to see the final outcome of the effort of Professor Saidur.
Yeah.
Please show us what you have done so far.
Go back. Back. Go back. Okay. So this is our final picture. Because we have done the IVAS after 4 into 8 millimeter balloon. With also we have done a 2.75 NC balloon in distally for distal optimization dot. and port done by 4 into 8 millimeter balloon. And the final IVUS, please, Dr. Akasaka can comment.
Yeah, this is a distal edge and round shape and nearly 3 millimeter, right? And
yeah.
Yeah, right. Yeah.
Oh, what is the MSA in the left main?
MSA is 9.5.
That part is a little bit under
Yeah,
expanded.
in Bangladeshi, you know, for this part of the planet, 9.5 is reasonable.
Yeah.
9.5 to 10.
No, Saidur, I think so. We need more number in case of the left main.
Not all the time, because this is, you know, a smaller calibered vessel.
Yeah, landing site of the left main orifice is very good.
And also the IVUS is telling that almost opposed. Right, Dr. Akasaka?
Yes, yes. And
yeah. Are you happy? Are you happy with the IVUS?
Just one portion, I'm afraid, a little bit under expansion, right?
Yeah,
Yes.
yeah. A small segment. I didn't go for that much.
Your IVUS is 40 frames or 60? 40.
Yeah, it's no. We have OCT, so we can't push our authority for 60 yet. But pray for us, maybe they will agree.
Okay, if we don't have any more questions to Professor Saidur, thank you, Saidur, for joining us.
Thank you very much.
On a Friday afternoon, sacrificing your weekly holiday. Thank you very much on behalf of BIT for your brilliant
Thank you,
job.
and I'm also honored, and I'm just also giving thanks to all my co-staffs.
Yeah, your team.
In this
we
weekend,
want
they
to
have come
congratulate you and our gratitude to you. And Professor Azizul Haq wanted to make a comment on Dr. Mamas's
I have a comment here.
Lecture.
The comment here for Dr. Saidur. This is a patient of renal failure, isn't it?
No, it's a creatinine level is 1.5, but mild CKD is there, but EGFR is around 35.
Around how much?
Around 35 to 40.
But still, it's a little bit jeopardized. What will be your comment about you used a lot of dye for this patient?
No, not that much contrast I have used. I have used just only 90 cc.
Okay, thank you.
Okay.
Dr. Saidur, thank you for nice and challenging case. Can you show the right side? You did.
Oh, the right side I will do. Right side I will do.
It will be a stage procedure, hopefully.
After 7 days I will do it.
Mamas from the UK here. I'm rather uncomfortable with the final MSA of the left main. I mean, it's 9 millimeters squared. We know from Kang data from South Korea, which again have small body sizes, that if you leave an MSA of 9 millimeters squared, your MACE rate is something like 24% in these cases. So, I mean, I appreciate it may be challenging, but I really would encourage you to try to get the MSA larger in that segment that is clearly underexpanded. It's well opposed, but it's clearly underexpanded, and this lady will get a MACE event. She has a 1 in 4 chance of getting a MACE event if you leave it like this.
I was also expecting, Dr. Mama, I was also expecting around 11 or 11.5. But I couldn't push that much actually. 4, 8 balloon and enough expansion up.
No, what is the reason? Why you did not more? Because why? What is the reason? Because you have done IVL. You said that you have cracked the IVL.
Yeah.
And the calcium.
Yeah, that's true.
And does the IVL was inadequate size?
No, it's a 3.5.
Okay, we are almost approaching.
Yes, it is 1:1.
1:1.
The end of the session. Professor Akasuka, do you like to make any comment before we conclude?
Yeah, my comment. I'm sorry, I'm really late, so I cannot understand what really happened from the first. But I think the calcium is the one of the important topic, and how to diagnose and how to treat by the imaging is very important. So I would like to say, if the calcium is very thick, we cannot make a crack, right? Therefore, IVL is very effective at the moment. But by eye was sometimes very difficult to understand the thickness of the calcium. We can speculate the thickness by the reverberation of the signal, but it is not so accurate. Therefore, OCT might be the better way to identify the thickness of calcium and the scoring system. But anyway, if you have a calcium crack, you can expect the wonderful expansion of the stent. And the under expansion of the stent, as you may know, is the most predictive value for the poor prognosis for this stenosis. That is the reason why we try to use the imaging, especially in case with calcium, right? That is my final comment. And congratulations, not the
Dr. Akasaka, we have the OCT also, but you know that as the patient is a CKD case, so I didn't go for the OCT here.
Okay, Professor Amol, about the live case and the lecture followed by the live case.
Thank you, Khalid Marshin sir. Thank you, Afzal sir, for giving me an opportunity to take participation in discussion in live case. I think it is thought-provoking as well as Dr. Saidur said and demonstrated very nicely. Thank you, sir.
I now hand over the microphone to Dr. Afsar Raza for his concluding remarks, and with his remarks, the session will be closed.
Thank you so much for the operator and the presenters who have done excellent and gave lectures to educate everyone, particularly the intravascular ultrasound we enjoyed from the live session. So I am thankful to everyone, all the presenters, the operators, and the panelists. Thank you.
I think we have a gap of about 1.5 hours here. So it will be the opening session will start at 7, but there will be some sessions in the other rooms around. So I would request you to attend those sessions and come back here around 7 o'clock for the opening ceremony.
So everybody should come at 7. We know that our chief advisor give a speech on the opening session. So everybody please come at 7, sharp at 7.
Recording stopped.